Namaste. Welcome to this IAS 2025 affiliated independent event in lead up to the 13th International AIDS Society Conference on HIV Science, which we commonly call IAS 2025. The theme of this session is Strengthening Competencies and Capacities of Global South to End AIDS, End TB, and Deliver on SDG 3. This event is co-hosted by UNAIDS Communities Delegation, TB People Global, TB People Zimbabwe, Humana People to People India, TB People Botswana, TB People Uganda, TB People India, National Coalition of People Living with HIV in India, or NCPI Plus as we call it, Positive Women Together in Action from Eswatini, People's Health Organization, Gujarat's Aid Awareness and Prevention, that is GAP, Taal Plus, Integrated Healthcare, Asia Pacific Media Alliance for Health and Development, or APCAT Media, Global AMR Media Alliance, GAMA, and CNS. Friends, we know that the world was not on track to end AIDS or to end TB by 2030, even before the COVID-19 pandemic and before the recent funding crisis had hit us. The latest Oxfam report, which was released at Financing for Development meet in Seville, Spain this week, shows that since 2015, the top 1% people in the world have amassed 33.9 trillion US dollars in new wealth, which is enough to end annual poverty 22 times over. We need health responses to be fully funded, of course, but we also have to ensure that equity and justice guides us on how we use those resources so that we are able to first serve those farthest behind or most likely to be left behind. It is not the absence of science-based tools that has failed the Global South on responding to key health epidemics, be it infectious diseases or non-communicable diseases, but deep-rooted equities and injustices that plague our so-called world order. If we are to deliver on promises enshrined in SDG 3 related to HIV and TB and other health issues, we must strengthen competencies and capacities in the Global South. Is A for accountability missing in global health? We need accountability from the governments to deliver on all promises enshrined in the political declarations of UN high-level meetings on TB, NCDs, AMR, and SDGs, among others, rather than just shift the goalpost by years. Let us begin on a positive note today by celebrating 25 plus years of leadership of Network of Maharashtra People Living with HIV, or NMP Plus as we call it. Our dear friend Annabelle Mandeng, who is a famous German film and TV actress, has sent her congratulatory video message. Annabelle has been a supporter of HIV and rights movements for over 2 decades now and has hosted events like the Artists Against AIDS Gala in Berlin. She also moderated the opening ceremony of the International AIDS Conference, AIDS 2024. Let us listen to her message.
Hello and warm greetings to everyone. I join you all to celebrate 25 plus years of network of Maharashtra people with HIV or NMP+. When I read about NMP+, the immortal words of Margaret Mead come to my mind. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Over 50,000 people living with HIV from all gender diversities can live a life of rights and human dignity, thanks to NMP+. NMP+ has helped people with HIV to care for each other, as well as rise collectively to improve HIV responses in their state. Congratulations, Manoj, Pardeshi, and NMP+ leaders for developing and leveraging social enterprise approaches for the last 2 decades, so that NMP+ and each one of you can be less dependent on external funding. Taal Plus, or a treatment advocacy adherence literacy, is a community-run pharmacy based on social enterprise that has been up and running since 2006. Taal is a shining example today for other civil societies to inspire them to use social enterprise and become self-reliant. It is the first ever community-led e-pharmacy in India. Over the years, it has transitioned into an integrated healthcare center, as well as managing an online platform since 2023. It offers in-person and online consultation, counseling, as well as quality assured and affordable life-saving medicines for HIV, STIs, and other co-infections and comorbidities. Screening for infectious and non-communicable diseases is also provided, along with a linkage to care services. Over 3,200 people receive life-saving antiretroviral therapy, along with other care services. Pre-exposure prophylaxis and other HIV prevention tools are also available via Taal Plus, T-A-A-L Plus. I was so proud to learn at AIDS 2024 in Munich that Taal Plus revenues have increased by 75% during 2023, from 155,000 in 2022 to 328,000 in 23. With around 10% profit generated annually, today Taal Plus not only addresses the quality of care needs of people living with HIV, but also channelizes resources back into NMP Plus to cover its annual funding needs. Congratulations, everyone at NMP Plus. We look forward to your continued leadership on the ground to help accelerate progress towards ending AIDS by 2030. All the best from Munich in Germany.
Thank you very much, Annabelle. Your message means a lot to us. Let us now listen to Dr. B.B. Rewari, who had shaped India's rollout of life-saving antiretroviral therapy for over a decade, and then led WHO CRO as regional advisor for hepatitis, HIV, and STIs.
Good morning, good afternoon, everyone. I'm quite happy to note that NMP Plus, along with other partners, is holding this important dialogue as an IS affiliated event on strengthening competencies and capacities of Global South to end AIDS, TB, and deliver on SDG 3. We know that world has achieved major progress in its response to HIV/AIDS epidemic, with significant reduction in new infections, AIDS-related death, and improving lives of people living with HIV. Community has played a big role in this journey, especially in empowering PL-HIV and reducing stigma and discrimination. NMP Plus is one such organization which started working for PL-HIV quite early in year 2000, when stigma was high and access to treatment was an issue. NMP Plus provided a platform for positive individuals to support each other, foster self-esteem. Over the years, it has worked tirelessly to uphold dignity and rights of people living with HIV. Their work has helped transform AIDS-related stigma into self-confidence, fear into hope, and shame into self-respect. It has worked closely with the government to raise treatment literacy. Some of the key projects by NMP Plus include access to care and treatment, Chaha project for children, youth rights, and recent targeted intervention for migrants. Today, the network of positive people in Maharashtra proudly stands as a symbol of resilience and a voice for people living with HIV and vulnerable communities. This year is special as it marks 25 years of NMP Plus unwavering commitment to community empowerment and strengthening India's response. All the best, Team NMP Plus, for your present and future initiatives on way to ending AIDS by 2030.
Thank you, sir. We have a message from David Bridger also, who is UNAIDS India Country Director.
Namaste, everybody. My name is David Bridger, and I'm the Country Director for UNAIDS here in India. I'm beaming in today because I wanted to say a few words in marking a very important milestone this year. 25 years of supporting and advocating for the lives of people living with HIV is such an important achievement. Let me offer my personal voice and that of the UN Joint Programme on HIV and AIDS in thanking each and everyone, past and present members and supporters of the National Network of Maharashtra of people living with HIV/AIDS for your tireless efforts and support. We've seen tremendous progress in the national, regional, and global HIV response these past 25 years, and that has largely been because of your efforts. Your joint efforts in defending the rights of people living with HIV and for the care and support you have offered and continue to deliver. The UN Joint Programme on HIV and AIDS offers our sincere thanks, and we commit to stand with you on this journey as it continues. Today, we celebrate 25 years of hard work and progress, but at the same time, reflect on what we still need to achieve to truly end AIDS as a public health threat. I think today is also really important for us to reflect and recognize that your efforts have not only supported people living with HIV, but they've also transformed public health approaches globally. Putting people at the center is now an approach widely accepted. A great deal of these changes are based on the learnings from the very models you helped develop and pioneer. Today, I send all my love and support to truly celebrate each of you and to remember those we have lost these past 25 years. Their memory and their efforts will never be forgotten. Thank you.
Thank you, David. I now invite NMP Plus co-founder and my dear friend Manoj Pardeshi. Manoj also co-founded NCPI Plus National Coalition of People Living with HIV in India, and he is the key architect of social enterprise model Taal Plus. Over to you, Manoj.
First of all, thank you so much for all the people, those who are taken the time and attended, joined this call. My special thanks to Annabella, Dr. Rewari, who is not only a doctor, but he is very a good friend. And together we have designed lots of work together on lots of challenges of country's treatment program. And UNAIDS and David, like those are the pillar who initial stage gave us the platform to build our capacity to gave us the opportunity to interact with lots of like political engagement and policy dialogue, facilitated dialogue with UN agencies, and tremendous role played by UNAIDS in these 3 decades. And all my friends, those who are drowned online. This this moment of 25 years, frankly, we never thought when we started this organization, we never dreamt also that we will be here to see this moment. And initially, we used to plan 3 months, 6 months, or maximum 1 year action plan. We really never thought that we will complete this 25 years. And this credit goes to all our well-wishers, friends, those who stood with us, our community who has gave the power to face every challenge with smile and with courage. So with this word, I thanks each and every one of you for being the companion and friends, philosopher and guide in this journey. Thank you so much.
Thank you, Manoj. Moving forward, I invite our friend, mentor, and guide for almost 2 decades, Dr. Kuldeep Singh Sachdeva, to set the stage for South-South collaboration. What can we learn from within the global South in responding to health threats like TB and HIV and other SDGs? Dr. Sachdeva is the former head of India's national TB and HIV programs, former Southeast Asia Director of International Union Against TB and Lung Disease, what we call the Union, and he currently serves as President and CMO, Molbio Diagnostics. Welcome, sir, and over to you.
Thank you, Shobha. I hope Bobby can play my slides when or so all my colleagues in the opening session, Shobha Shukla, Bobby Ramakant, Annabelle, Manoj Pardeshi, Dr. Rewari, Dr. Gilada, and other esteemed dignitaries present online. Good morning, good afternoon, good evening, whichever part of the world you are. So the topic which has been assigned to me is about South-South collaboration, how countries of Global South can help other countries of Global South to pick it up, to learn from each other, share knowledge and take ahead. And specifically, we'll talk about healthcare. Next slide, please. So the discussion is primarily centered around the Sustainable Development Goal 3, mainly around TB, HIV, and other diseases under this SDG 3, and how do we actually learn from each other. So a word about South-South collaboration, it is an approach amongst developing countries in the Global South to share knowledge, resources, and expertise. Aim is to foster development through mutual learning and shared solutions, reducing dependence on traditional aid from the global north and promoting a more balanced global landscape. It's a horizontal, equal partnership between countries, and it's based on principle of solidarity and shared goals rather than a hierarchical relationship. So we share best experiences, best practices, and technical know-how to address common challenges. We also pool resources and expertise to tackle development challenges collectively. The most common mechanism which comes to mind are Indo-African Partnership, Brazil, Russia, India, China, South African platform called BRICS, and many more on the same platform. Next, please. So these are some examples of the South-to-South collaboration which I've picked up from various resources. So one is called an IBSA fund, which is India, Brazil, South Africa fund, which supports various development projects in other developing countries, including healthcare. And they have supported the constructions of community health centers in Haiti and contributed to improving healthcare infrastructure and services. India has been a strong proponent of South-South cooperation, particularly in health sector, and has provided medical supplies and support to other developing countries in needs of exigencies and emergencies. And also during COVID, we have seen India shared some of the vaccines with countries of the Global South. There's another example of Cuba's assistance in West Africa during the Ebola outbreak. Cuba had sent medical teams and personnel to visit to West African countries, and thus demonstrating solidarity and expertise in managing infectious disease. The examples are endless. All those present here will come up with many more examples. I'm talking from my limited experience in this South-South collaboration. Next slide, please. Now, having said that, what is the India's take on South-South collaboration? So this is just to showcase that one particular parliament question raised in the parliament, where India said we are committed towards addressing the needs and aspirations of fellow developing countries, and has been constructively championing the cause of holistic, human-centric development of countries in Global South in various international forums. With this view, the Government of India has also undertaken several development partnership initiatives to promote self-reliance among countries of the global south, including, I'm not reading the whole text, only the relevant portion. And the other relevant portion is in the G20 summit, the African Union has been included as a permanent member during India's G20 presidency, and that again sort of exemplifies our commitment to South-South collaboration. So South-South collaboration is more between countries, but there are also collaborations which I have not put on this slide between industry and academia on from south to south. And various industries are actually with their new innovative products and collaborations are contributing to the needs of the other countries. And of particular relevance here is a large portion of anti-TB drugs is sourced, made, manufactured in India and sourced globally at a very competitive or a cheap cost across the globe, thus bringing down prices phenomenally. So companies like Lupin, McLeod's contribute a lot to that endeavor. On the diagnostic front, our own company, Molbio Diagnostics, which manufactures TrueNat platform, which is a miniaturized PCR platform, has been distributing and supplying these platforms and cartridges to almost 85 countries in the global south, mostly LMICs, lower middle income countries, at a very, very competitive cost. Again, example of how production or industry in south is supporting the needs of the other global south countries. Similar example in vaccine comes from Serum Institute of India, which actually supplies to almost more than 2/3 of the world the vaccines need for the population. We all know the example of a company called Cipla, which reduced the drug prices of anti-HIV medicines almost by 6 to 10 folds by making generics in way back about 2 to 3 decades ago. So there are numerous examples. Many of you present here will come out with many more, which I may not be aware of, and your countries may be contributing to other global south countries. So please share those examples in the chat box or later share them with Shobha, which she can then collate and share with all of us. I'll move to the next slide and request to move to the next slide. I also was searching through some publication and came across this publication where they have said one south-to-south collaboration which help in scale up of HIV care and building capacity for HIV care. And this refers to Haiti-Lesotho collaborative model showing that human resource capacity can be built using creative partnerships and exchanges between developing countries, particularly with financial support from the north. So here the funding was from the global north. The collaboration allowed for a sharing of experiences and solution through perspectives and experiences that are unique to developing countries. Healthcare workers in Haiti and Lesotho have established meaningful and fruitful cross-country working relationships. Job satisfaction and retention has been improved as a sense of solidarity developed. The model of care developed in Haiti was successfully adapted, replicated, and implemented in Lesotho. In my capacity earlier as the program manager for both TB and HIV, we have also sort of had a cultural exchange with program managers from HIV and TB from many countries of global south, especially the African continent and the many other Southeast Asian countries. So that forum is still alive, and we share knowledge, share our technical expertise, and also help the global south in developing, showing them the best practices around. Next slide, please. This is one of the landmark project which was implemented by Government of India. It's called Pan-African E-Network Project, which was mainly an project on information technology in healthcare. It was an initiative of Government of India in collaboration with the African Union. Next slide, please. So I'm not going into the entire project per se, but just bringing a few aspects of this project where Indian super specialty hospitals were selected to be the telemedicine hubs, and the spokes were the other hospitals and users in the African Union. So the names of the super specialty hospitals are listed here. The first one is a tertiary care government hospital known as All India Institute of Medical Sciences, Delhi. And there are 11 other hospitals. So this is one example of, again, south to south collaboration. Next, please. The next slide showcases collaboration with universities and super specialties hospitals selected by the African Union. So we show that leading regional universities from Uganda, Ghana, Cameroon, Egypt, Malawi collaborated under this project. And the regional super specialty hospitals from Nigeria, Congo, Mauritius, Egypt, Senegal, again collaborated with this project. So there are numerous initiatives which many countries are doing among of global south or doing among themselves. I'm only trying to bring a few examples. Next slide, please. And this shows in this IT and health project, 48 countries from African Union joined the project and reaped the benefit of knowledge exchange, exchange of the technical expertise and the technology per se to further initiatives of the Global South. Next, please. This was my last slide. I'll be open to questions and other things, but this is just to give you a sense and example what countries from Global South can do to help other countries. So many things we are doing at present also, and we are always available to scale up. So these are a few examples. I hope some of you will share more examples and we can build on from there. Thank you for your attention, and thanks Shobha and Bobby for the opportunity.
Thank you very much, Dr. Sachdeva, for setting the stage today in as precise a manner as you always do. And we will take up the questions later on, and we are open for discussion once the speakers have presented.
Sure.
Let us now listen to the longest serving HIV medical expert in India, Dr. Ishwar Gilada, Governing Council member and Chair of Asia Pacific International AIDS Society and President Emeritus AIDS Society of India.
Thank you very much for taking my views. And my views are a little radical because what has been happening over the last decade, India's contribution to ART, antiretroviral treatment globally, has been 80% almost 10 years back. Currently it is 92% or more than 92%. That means that whatever number of people, whether they are 20 million or 22 million people who are taking ART, 92% people who are people living with HIV, they are taking ART made in India, made by Indian pharma companies, generic ARVs. And therefore, today, if the people in Africa and many lower and middle income countries, if they are alive, who are living with HIV and they are alive, that is thanks to India and Indian pharma companies. Whatever all these big organizations, including World Health Organization, UNAIDS, Global Fund, World Bank, or any bilateral, multilateral agencies, Gates Foundation, PEPFAR, whenever they declared any program in last 10 years, that is on the strength of India. What I'm saying is that if they talk about prevention, treatment as prevention, or TASP, or test and treat, or treat all, or post-exposure prophylaxis, pre-exposure prophylaxis, when they're talking about this, if they talk about their 8 or 10% of population of people living with HIV in their countries, that's fine. But when they're talking about globe, that means 92% of the global people living with HIV or those who are at risk of HIV and taking PEP maybe because of one-upmanship that we are the people, we are making the drug, we are the patent owners, we are the rich countries, and we can suppress and oppress the lower and middle income countries. That is one. Second thing is jealousy. By and large, people don't want to take India's name in a good sense anytime, particularly from Western countries. And we feel bad. Today, if you take any African country, any poor or lower income country, you go there, not only HIV, whether you talk about any infection like tuberculosis, other infectious diseases, antibiotics that they are consuming, they're all made in India. Now, I will go one step beyond that. If you talk about even the patent owner companies, you see all their products. Not all the products are made in their country. They are all, many of them are manufactured in India. They just may be labeling as XYZ company, but they are manufactured in India, and that is mentioned on their products also. So for their own people who can afford and who can pay the cost of innovator companies, fine. But for those people which are from the we need Indian pharma companies to subsidize or to produce at such a low cost which is accessible and affordable. And there is only one country in the world which can do that, is India. Though the innovator company Gilead may have given license to 6 companies, 4 are from India, 1 is from Pakistan, and 1 is from Egypt. If we are going to provide, and at what cost? We are looking at a benchmark cost of $100 against $28,128. So this is going to happen in next year, maybe a couple of months or so. But if you go to past, hepatitis C medicine, HCV medicine, HCV cure was also found by Gilead. Their cost was $1,000 per day, $84,000 for 84 days course. And when they realized that India can copy that, either India can get a compulsory license from our government, or they just forego patent and manufacture by different means and different ways. They automatically came to India and they gave a license to 11 companies. And they told the companies that $84,000 worth medicine you should produce in your Indian companies and sell it for $1,000. So on their own volition, they come down to 1% of international cost, 1% of their cost. However, the 12th company came from India, and that company said, why you choose and how you chose only 11? Why not me? And we'll defy your voluntary license also, we'll produce. Let us see what we can do. And that company produced, and that brought down the cost from $1,000 to $300. Today, hepatitis C cure is available from 11 plus 1, 12 companies from India at around $250 to $300. So can you imagine, this is 0.3% of global cost. Same thing with ARV, the quoted cost of per year 3 drug combination, when it was decided around 2005 or so, it was $10,452 per patient per year. And the lowest Indian quoted cost today is $69. So it is 0.6%, 0.7% of the international cost. Particularly in Angola, when I went to the pharmacy, I seen a medicine made from one of the Indian pharma companies. I don't want to take their name because I'm not representing any company. I'm representing my country. So I told those people that, look, this bottle it is coming from Brazil. I said, no, Hyderabad is in India. It is not in Brazil. And then following that, a delegation from Angola, led by the health minister of Angola, they visited us. They visited my clinic to see that. They visited the pharma companies to see how they are manufacture medicine, and then they started buying directly from India. The difference was what they were buying for $3, they were getting at $1 from India. So if medicine was going from Hyderabad to Delhi, Delhi to Brazil, and supplied to Africa or any LMIC, they are manufactured in a GMP, good manufacturing practice units, WHO pre-qualified units, PEPFAR or USFDA pre-qualified units. That means our medicines are no way standard, substandard.
Thank you very much, Dr. Gilada. Now we move on to a panel discussion on strengthening competencies and capacities of Global South to end AIDS, end TB, and deliver on SDG 3, the successes, challenges, and solutions. This panel would be chaired by Dr. B.B. Rewari. Dr. Rewari is currently a visiting professor of epidemiology and public health at ILBS in Delhi, an honorary clinical professor, Division of Global Health, University of Washington. He is a former regional advisor for viral hepatitis, HIV, and STIs for WHO CRO, and he formerly led and shaped India's ART program at National AIDS Control Organization, Ministry of Health and Family Welfare, Government of India. Over to you, sir. Yes, Dr. Rewari.
Hello, I think Dr. Rewari is yet to join the meeting. So while we wait for him, I will like to request the UNAIDS country director for Cambodia, Laos, and Malaysia, Patricia Ongpin. Patricia, welcome. Thank you for joining us. Patricia, as friends, you might have known, the first ever rollout of long-acting injectable pre-exposure prophylaxis using cabotegravir has happened last week, perhaps in Cambodia. So this is in Asia is the first ever, and as we know, there are 3 generic manufacturing companies, which I think perhaps they are all of the 3 are in India. So this is really important. Let us hope that all HIV combination prevention options, most of them are made in the Global South. They become available to everyone. Patricia, welcome. Over to you. Hello, hi Patricia. Please, can you try one more time? Oh yes, we can see you. Thank you. And congratulations, Cambodia. I think you are on a mute too.
Can you hear me now?
Yes, we can hear you loud and clear.
Perfect. Thank you so much for inviting me to speak about Cambodia's wonderful launch of Cabalé. Indeed, we just launched it last month in June. We are the second country in Asia to launch Cabalé, Thailand being the first, but this is still a momentous occasion for Asia Pacific to have such robust HIV prevention combination options in the region. So Cabalé is being rolled out in a phase-based approach here in Cambodia, first focusing on 4 clinics in Phnom Penh, the capital city of Cambodia, moving on to more sites in Phnom Penh until it reaches out to the high priority provinces of Siem Reap, Battambang, Banteay, Meanchey, Sihanoukville, and Kandal. To give you some context, this is a concentrated epidemic with 88% of our new HIV infections taking place amongst key populations. So this is a very targeted approach of providing Cabalé to our key populations. The Cabalé was procured through the Global Fund pool procurement process of WAMBO. Cambodia procured a branded version of Cabalé Apretude, which is manufactured in the UK. I know this is a question that you had asked me as well, Bobby. And moving forward, though, Cambodia is set to graduate the least development country status in 2029. What that means is that soon after, the TRIPS waivers will expire. Therefore, commodities and drugs in Cambodia will become more expensive. So moving forward, Cambodia needs to engage in conversations about generics, about reducing drug pricing for innovations such as CABA. In terms of South-to-South relations, the UNAIDS office here is a multi-country office. We cover Cambodia, Laos, and Malaysia. What this has done is provided a conducive environment for exchanging of information. Last year, in August of 2024, Lao PDR sent a group of, I believe it was 20 individuals across Ministry of Education, Health, the UN, CSO's government to learn about the HIV prevention options here in Cambodia so that they can take it back home to Laos to see what can they adopt. So that's just an example of another South-to-South collaboration where more information about prevention is being shared amongst countries, and we can encourage more countries within the ASEAN nations, within Asia Pacific in general, to adopt innovative preventions. And one exciting bit that Cambodia has in store as well, we're hoping in the next couple of months that Dapivirine ring is also going to be launched, which means it's an even more robust set of combination HIV prevention that will be available here in Cambodia. And we're hoping to inspire other countries within the Mekong region, within the ASEAN region, to look at long-acting injectables, to look at long-acting PrEP as a way to reduce HIV new infections. Thank you.
Thank you, Patricia. Thank you for telling us about the trailblazing activities of Cambodia. And we are all so proud of our entire global south, including your country. Thank you so much. I now invite Global Health Thought Leader, Dr. Sugata Mukhopadhyay, to share his insights. Dr. Mukhopadhyay has served in several countries, including Mozambique and India, and helped shape national HIV and TB responses. Several of the interventions designed with his help reach the unreached people with best of public services for HIV and TB. Over to you, sir.
Thank you, Shobhaji. Am I audible?
Yes, very audible. Yes.
Okay. Good morning and good afternoon. Namaste. I am Sugata Mukhopadhyay. I am from India. And at the beginning, let me express my sincere gratitude for giving me the opportunity to speak about the topic that is way forward in Global South for person-centered TB and HIV care. And I congratulate the people and the organizations for such collaborative initiative with the IAS 2025 and organize this very important event. I will try to keep my talk brief within the given time. Person-centered care for TB and HIV. It is a very critical discussion point at a situation when global health suffers from sudden funding cut, compromised logistics supply, and massive reduction of the number of caregivers. The current time necessitates to establish the principle of achieving much more with much less by rapid enhancement of the quality of the services and care, stronger engagement of the affected, infected, and vulnerable community members in the decision-making process, and promoting cost-effective interventions which have both scalability and impact. Person-centered care is focused and organized around the health needs and expectations of people and communities rather than just on the diseases. In a people-centered care, everyone is important as anyone else. There is no hierarchy, everyone involved, from patients to healthcare providers to families, social workers and community members, to contribute to a coordinated effort in the delivery of care and services. Person-centric care aims to replace unidirectional clinical approach with a health system community partnership approach, where the people, families, and communities are no more regarded merely as the beneficiaries of the healthcare services, but to be equally engaged in the crucial decision-making processes regarding policies, overall disease management, and continuum of care. We also use a terminology like patient-centered care, which is focused on the individuals seeking healthcare who are the patients. However, people-centered care should be much beyond the patient-centered care. Patients should not be reduced to or defined by their diseases or illnesses and conditions. They are persons with individual preferences, needs, and abilities who are full partners in their care. They are people, not cases, neither number to count and analyze. We also use a terminology like differentiated service delivery models, which are already in place in HIV program and also being initiated in TB, focus on more customized treatment and care according to the specific health and non-health needs of the people as an integral part of client-centered approach to reflect the preferences, expectations, and needs of the people while reducing unnecessary burden on the health system. The idea is not only to treat the health conditions, but also help the clients to overcome their health-related dysfunction and disabilities that can enhance their cure and sustain good health thereafter. In the same context, we should utilize person-centered care to equally address the emotional economic stability of the affected and infected people, address stigma, discrimination, violation of rights, gender equity, reduce out-of-pocket expenditure, organize livelihood opportunities and social protection to maximize impact of the treatment outcomes in TB and HIV. We know that the expected outcomes of a person-centered care are basically in TB, it is the successful completion of both curative and preventive treatment and sustained viral suppression in HIV, which can finally reduce the new TB and HIV cases and premature mortality. And here also we have to appreciate the roles of our CSO partners, TB champions, HIV champions, and community members. They are playing critical role to achieve these goals. And also there should be sustained advocacy to mobilize the Ministry of Health to adopt patient-friendly policies for integrated and holistic care. And that should be a priority. In the context of Global South, or more precisely in the context of high TB, high HIV, and high TB HIV and other co-infection and comorbidity settings, I want to share 3 critical messages to promote and strengthen person-centered care. So number 1 is, instead of merely collaborating TB and HIV interventions, can we think about a merged and unified TB HIV elimination program rather than separated TB and HIV control programs? Because that's what the people need. One program, one strategy, one implementation at the same healthcare settings by the same service providers. Incidentally, it is the same group of poor and vulnerable people of HIV programs who are also in the need of TB care and vice versa. So when clients are the same, why not the programs? Number 2 is enhance the treatment of contacts of TB and HIV index cases. We have to understand that a TB patient or an HIV infected person is actually part of a group of potential affected and infected people whom we call close contacts in TB and sexual contacts in HIV. The index cases of TB and HIV should be treated in tandem with all their possible contacts with the help of an appropriate curative and preventive treatment package, and to be monitored together to ensure completion of the curative and preventive treatment in the same go. People should be empowered to demand screening and treatment of their partners as part of the person-centered care. And lastly, there should be more capacities for person-centered care for TB and HIV that has to be built at the country level. And there should be appropriate guidance and cross-learning materials for strengthening person-centered care both for providers and people, like operational manuals, lesson learned documents, patient information materials, patient charters, stigma assessment tools, etc. Equally, we should encourage community members for self and community monitoring for the progresses of the health condition status of health services. And they should be also encouraged to utilize available digital applications for such monitorings. Thank you so much. That's basically the things I have to say. And finally, thanks to CNS, IAS, and all the people for giving me this opportunity. Thank you, and good luck to everyone.
Thank you, Shukla, and thank you for your very, very valuable insights and suggestions. Now we are happy to have Dr. Rewari with us, and he will chair the panel discussion on strengthening competencies and capacities of Global South to end AIDS, end TB, and deliver on SDG 3, the successes, challenges, and solutions. As we know, Dr. Rewari is currently a visiting professor of epidemiology and public health at ILBS in Delhi and honorary clinical professor, Division of Global Health at University of Washington. He is a former regional advisor for viral hepatitis, HIV, and STIs for WHO CRO, and he formerly led and shaped India's ART program at National AIDS Control Organization, Ministry of Health and Family Welfare, Government of India. Over to you, sir.
Good afternoon, good morning, good afternoon. Thank you, Shobha, Bobby, and CNS for giving me this opportunity and taking up this very important part of inequities, basically, in terms of response in Global South. So if we really look into this before we go to the session, we know that inequities in the response in Global South, they are significant, they are multifaceted, and they lead to disparities in the infection rate, access to treatment, and overall health outcomes. While these inequalities are fueled by factors like poverty, gender inequality, stigma, discrimination, and also, if you see now the key disruption to health systems, which is sudden and major cut to health and funding, we know all that, reduced and shrinking HRH, loss of partners, disruption of some essential health services, disrupted supply chain issues. So these are some of the other issues basically which are coming in, which are likely to further basically accentuate these inequalities that we have seen. So to effectively combat AIDS, TB, and deliver on SDG 3, basically, particularly in Global South, we know the strengthening the competencies and capacities is crucial. This involves enhancing technical expertise, improving infrastructure, fostering community engagement, rather bringing back the community engagement, the kind of community engagement we have seen in the past that has dwindled, and promoting sustainable financing mechanism. So the year 2025 marks the historic point when Global Fund has procured Africa-made life-saving drugs. Another highlight is basically that Africa CDC and UNAIDS have formed a new strategic partnership during the World Health Assembly in May 2025. So these are some of the opportunities which basically we need to look into, and we have got very learned panelists in this session. Though it is for 60 minutes, we have 7 panelists. So I would request all the panelists to keep your remarks to maximum of 5 minutes. So we'll start with UNAIDS. We have Mr. Ademola, who is sourcing lead, access, and regional manufacturing at UNAIDS. Mr. Ademola, UNAIDS announced last month that CDC Africa, along with them, they will make essential health products, including APIs, within Africa. This is very important, we feel. But can you give us some more little details about this partnership and how we are moving ahead, and how will this help in basically plugging the gap that we have in terms of access? Over to you.
Thank you very much, Mr. Bharat. As UNAIDS, we've actually consistently worked with industry and technical partners to facilitate equitable access to the best health products. And we've done this for over 17 years. We've worked very closely with partners like the Clinton Health Access Initiative, partners like the Global Fund, PEPFAR, and most importantly, industry partners to ensure that we are able to accelerate the pace and the prioritization of the best in class HIV products over the years. Now, as we started in the past 4 or 5 years, looking at our new strategic period, we started to reflect on how the market has progressed significantly. And when we say the market has progressed significantly, over a decade and a half ago, when we were working on many of the earlier HIV products, you needed multiple countries to be able to make minimum order quantities, for example, with some of the pharmaceutical companies. Today, we do have a market that is able to sustain or be serviced by multiple manufacturers. That's one point. The other point is that as we have progressed with advocacy of many of the stakeholders on this call, we are beginning to see governments start to step up. And of course, most importantly, this year with the recent funding cuts, this has been further accentuated. And what we're seeing is that, with the fact that there's going to be increased government funding, there is a potential risk for some sort of fragmentation, but also a need to also decentralize some of the manufacturing capabilities. So it's on this note that UNITAID set up a strategic initiative called Regional Manufacturing for Equitable Access. And the focus here is that we believe that within the basket of products and innovations that UNITAID supports, there are going to be some unique products that are best suited with the right market size, with the right capabilities, and the right South-South partnerships for manufacturing in underserved regions, looking at Africa, Latin America, and maybe at the later stage, some other Southeast Asian countries. And so on that basis, we set up this program and we initiated we're in the process of initiating its first phase. And what we did as UNITAID is to then conduct a very strategic assessment of our portfolio and narrow it down to 3 product categories. One would be HIV products, which would include, to the extent possible, prevention products. The other would be maternal health products, focusing first on postpartum hemorrhage products and subsequently looking at preeclampsia, eclampsia tools. And the third would be malaria products. And so we have built business cases. We have set up some partnerships with the continental institutions, and we look forward to being able to launch this initiative at the beginning of, we're now in July, so it's definitely in this quarter of this year is when we're looking to be able to launch this initiative. And so we're very, very excited of the opportunity to partner with the industry, facilitate collaboration between, increased South-South collaboration. I see that my friend Palu is on the call. Palu has been a very good partner. Universal has been a partner to UNITAID, and we do congratulate them on the most recent feat of supplying to Mozambique, and we do see an opportunity to do more with partners like Universal. I'll pause here in case there could be more questions to have some more time for the other panelists. Thank you.
Thank you, Anmula. This is a very unique initiative because South Africa has got 25% of global disease burden, yet they import 90%, 95% of APIs and 70% of medicine they consume are imported. So this partnership becomes very important and strategic. But I have a question basically. Do we have some assurance from the pharma companies within Africa who will make these medicines? Or you are trying to tie up with some other companies, maybe in India or other countries who will have partnership kind of thing for manufacturing it there? That is the question number 1. And second is basically, will this be a national procurement? Because of course the funding landscape has changed now, and there is no PEPFAR funding for these countries. But do you think Global Fund will also allow procure, because there will be issue of the pre-qualification? These will not be WHO pre-qualified in the beginning. So will that impact it? Over.
So I think I'll start from the last part of your comment. I think the most important thing and the intervention that would be put in place is to ensure that we're able to improve the cost and the quality of the products, of additional products being made on the continent, because there are already products that are being made competitively on the continent, and I'm sure Palu will speak to that later. That's one. So I just wanted to clarify that, and that would include going through, the different quality assurance mechanisms, including WHO pre-qualification, but also leveraging mechanisms like the expert review panel that we had set up in partnership with the Global Fund before now. So ensuring that we have accelerated review pathways, but also we leverage the new and emerging quality assurance mechanisms like the medical medicines regulatory harmonization initiatives in Africa, but also the recently formed Africa Medicines Agency. So we'll be leveraging that. On procurement mechanisms, I touched on this a bit earlier, talking about the issue of, the what I could almost call positive fragmentation. So with governments beginning to fund more, there's likely going to be some measure of fragmentation. And so we're working with the Global Fund and other partners to support the regional economic communities to further strengthen their pooled procurement mechanisms. So we're looking at, leveraging what we've learned from the global pooled procurement mechanisms like those of the Global Fund, and being able to partner with regional pool procurement mechanism. Currently, we're working very closely with the South African Development Community, SADC, to set up their SADC pool procurement services system. And this is work we're doing in partnership with the Global Fund. And I believe there should be a colleague from the Global Fund that could speak more to this later. And in terms of commitment, I think that the excellent thing that we've experienced is that one of the things we did as we were putting out a call for proposal for technical partners, we also put out a call for expressions of interest from industry. And I must report back that we've had over 50 responses from a lot of companies, both those that are solely in Africa, but also some that have partnerships in India, and some of the India pharma have also expressed interest to work with us on this very great initiative. So that process will be taken further as soon as our board approves the final phase of the investments that we'll be setting up, which we expect should happen, in a matter of days. If we, subject to board approval. And so we're looking forward to being able to work with these companies that have expressed interest to participate in this initiative. Over.
Thank you for the response. It is very heartening to note that you have been in dialogue with the companies, and some of the Indian pharmaceutical, which have been major supplier, particularly for ARVs, they have expressed interest in the partnership. I think this is a very good first step that has been taken. And I'm very happy to invite Ms. Clarice Morris, Manager Marketing, Market Shaping and Partnership from Global Fund, because as you rightly said, Global Fund has also expressed interest, and they've already procured Africa-made ARVs for the first time last month from Kenya's UCL and delivered it to Mozambique. So this is a very good next step when we say all these innovations, manufacturing, supply chain, which have become a greater challenge now because of donor funding landscape. It has changed, with particularly PEPFAR moving out, reducing their funding support. So, Ms. Clarice, over to you for your remarks on basically how do you feel, how will you expand this further, the step that you've already been taken? Over.
Thank you, and thanks for the opportunity to speak at this important meeting. So building resilient regional manufacturing, and when we speak about regional manufacturing at Global Fund, we're focusing on Africa in this instance because we see the biggest gap there. And it's central to the Global Fund's vision for equitable and sustainable access to quality assured health products, particularly for HIV, TB, and malaria. Because bringing production closer to our health products are needed, ensures faster and more reliable supply chains, and reduces dependence on external markets. So we support regional manufacturing by leveraging our procurement power, our market intelligence, and partnerships such as UNAIDS and also the World Health Organization. We use those partnerships to strengthen regulatory systems, enable country adoption of quality assured health products, and to fund capacity building through our next-gen market shaping framework. But we do not directly invest in firms or provide capital, right? Because we are a major procurer and that would be a conflict of interest. So that's out of scope. One of the things we're doing is investing in demand-based technical assistance to accelerate the readiness of African manufacturers. And the readiness is basically related to the quality. So just like you questioned Ademola earlier, we help to support these manufacturers to reach WHO pre-qualification level or expert review level. And we've provided support via the WHO's local production and assistance unit. And also, as was just mentioned, we set up a specific expert review panel together with UNAIDS and WHO for African manufactured HIV rapid test kits, because we see a gap there. There's not enough on the market, and it would really be a transferable skill as well. Once African manufacturers can produce these products at quality, they can use that same technology to develop other rapid diagnostic test kits. And as was mentioned, we have begun procuring regionally manufactured ARVs this year. And I understand UCL is on the panel as well. And we see this as a pivotal step in realizing local manufacturing to make sure that life-saving HIV treatment is available in Africa. But we realize that it's just the beginning, right? We're not done yet, and we need to continue this effort and increase it. We do see a gap, though, on regulatory readiness on the continent, and that's why we collaborate also with WHO and AUDA-NEPA to support regulatory harmonization, because that's one of the key levers that we see. If we can unblock that, it will strengthen the market size and increase demand to support manufacturing efficiencies, because right now it is still an issue of having low volumes, and it's difficult to have a regional market if all the standards are different. Now, our pooled procurement mechanism was also mentioned by one of the speakers, wambo.org. So we procure about $2 billion worth of health commodities every year, which are procured by 85 countries. And increasingly, we are integrating regional manufacturers, so African manufacturers, to diversify our supply base and to support local manufacturing ecosystems. And of course, UCL is one of them, and there's a few other ones, but we'd like to see more that meet the quality assurance standards. As mentioned earlier as well, we're working with regional pooled procurement platforms and with UNAIDS to build institutional capacity, which includes SADC, it includes also, I think, the East African community and ECOWAS, and that will help them to improve demand forecasting and facilitate potential joint tendering or other collaborative procurement approaches that ensure that African manufacturing can have better structured, aggregated demand that enables scale and long-term viability. Beyond procurement, the Global Fund is also a convener of partners, facilitating South-South knowledge transfer, aligning actors across manufacturing, regulation, procurement, and financing. And we're also looking at our next grant cycle, which will start in 2027, to explore innovative approaches and increasing participation of African manufacturers and looking at new partnerships to make that happen. So it's still a health priority, and we have not stepped back. We're actually hoping to increase our efforts together with partners, even though, the situation has changed a lot in the ecosystem. But we see that this is a vital component of making sure that Africa becomes more resilient and able to respond to its own health needs. So I will stop there in case there are other questions. Thank you.
Thank you, Clarice. That was very important. And it is a very good step in the sense, basically, as the Global Fund invests into these medicines, it is bound to have a positive impact on the GDP growth, regional trade, and of course, the foreign currency requirement. All those things are going to be helpful to the countries. But moving ahead, are you restricting yourself to medicines only, or this will extend to diagnostics? And very important question, because now we are trying to change the scenario of the global north or the donor countries, which basically many times dictate you where from to buy, which pre-qualified or which source of funding. Are there any, do you feel, are there any pressures, or there are going to be some issues on that aspect also? Over.
So maybe on the first point, no, we're not limiting ourselves to pharmaceuticals. As I mentioned, we've opened up this expert review panel pathway for diagnostics, so rapid diagnostics, so that we can hopefully get African manufacturers to meet that first level of quality so that we can start procuring as Global Fund. The important thing is, though, that those products do need to eventually meet the WHO pre-qualification level. But we have set up this initial point so that we can start procuring earlier while the product is on the pathway for WHO pre-qualification. And we have also updated our quality assurance policy, I think last year, to include WHO listed authorities as well, which ideally would include African ones. So we're not limiting ourselves only to pre-qualification. We hope that as African regulatory authorities increase their quality levels, their maturity level, they can at some point be included. And products that they evaluate can be procured by Global Fund. Now, what was your last, sorry, your second question?
Basically, it was any kind of pressure you may have from the global north, from the donors who provide money to particularly buy from particular, like PEPFAR, they have to source from particular company or something like that. Will that be a kind of conflict?
No. So what we're seeing is that there's actually increased interest from donors, like the European Commission, for us to buy more from Africa. And they're also looking at how to invest to make that happen. So I think the current situation with the changes in funding and the, I guess, increased importance for resilience in Africa actually has donors looking more at how can we help Africa get there. So I think it's a good sign. And we do need many partners to be involved. There's no one solution, or no one has all the funding to do everything that's needed, and it's also going to take time. But from what I see from UK, from EC, from France, even other countries, the donors are interested in seeing how are we working with African institutions to ensure that there is quality assured supply from the continent for the continent. So I think things are going in a positive direction, and there's momentum now.
Okay, thank you.
And I see some questions in the chat. I will type in the chat after.
Yeah,
thank you.
I'm not looking at the chat right now, but maybe once we are done, we can look into chat. A question related to your part, all the panelists can reply in the chat itself because very limited time we have. So we move on further, congratulating the UCL. We have Mr. Palu Dhanani, who is Managing Director of UCL. Congratulations, Mr. Palu Dhanani. This was a great historic procurement. It was happy to note that this was WHO pre-qualified TLD that was supplied to Mozambique through Global Fund. So that was a great development, basically. I congratulate you on that and would like to listen from you. How are you going to basically expand this activity? What are the manufacturing capacities within the UCL so that you can meet the need of other countries within the Africa? Over.
Wow, thank you very much. Thanks for the invite. It's been great to be around. I don't know how to switch on my camera, but so as I say, thank you very much. It was nice to hear from Clarice and the rest of the team at the MOLA. I think one thing we need to understand is how much is the HIV burden of the whole world in sub-Saharan Africa. It is about 65%. Malaria is over 90%. How much of it is being procured from the continent? There's a good start. I think I really appreciate the support from the donors. GF has actually started doing something, UNICEF, UNAIDS, MMV, all those people have supported us in the journey towards growth. PEPFAR, USAID, the former USAID. So thanks to that, and I see there is a lot of progress and positivity towards that angle of local procurement. However, there are challenges. To run a PQ plant, it's not a walk in the park because it increases your cost base. And when it increases your cost base, it makes you more expensive in the private sector for the other items. So we become very non-competitive in the local government tenders for the other items, which means now we need more support in terms of quality. So all these endeavors that everybody is doing to increase the quality levels as far as the regulators are concerned, it's a well appreciated fact, but that's going to take time. So if I give an example, or during the COVID time, there were shortages of critical items on the continent. And when I say that, I have a good example of cotrimoxazole, which is an ancillary product to HIV. Thanks to WHO, thanks to Global Fund, they had a contract with us for about 22 countries or 19 countries in that period. None of the countries ran out of stock. All the countries that were relying on imports all had challenges in terms of that product. Maybe there are other products are there, but I can just give you that example that we serviced almost 19 countries sitting in Kenya with zero out of stock. Delays were there, yes, but zero out of stock. So there are good examples of that. However, we are talking about reduced funding now, whether it is, the USAID program or the PEPFAR program. We have started talking of self-sustainability by governments.
Mango काटेगा
So
भाई?
clearly we need, sorry. So clearly we need help in terms of developing capacity of quality medicine manufacturers on the continent. And if it's not going to be a sustainable procurement, are people going to invest in quality procurement in future? We asked about new products pipeline. I mean, we are on the journey. I mean, we have been pre-qualified for 14 years. It's not a walk in the park that we did it once and got away with it. Our first pre-qualification was in 2011. The first procurement of the PQ product happened last year. So there was a gap. What the gap was, let's not go into that for now. But I think we need more sustainable orders for us to invest more. And we have kept on investing. Apart from the HIV product, which is a technology transfer from Strides, we developed the dispersible SP and SPAQ, which is an anti-malarial, in conjunction with UNAIDS and MMV. Even there, we got the first order from Mali through Global Fund. Thank you again. But again, as I say, is it sustainable? So we are willing, okay, we are more expensive than the reference price by maybe 3 to 7%. So it's not out of the blue. And we are willing to walk the journey to make it within the reference price of the Global Fund. However, we need some volume commitments to help us achieve that. Because if we get an order now and then for 6 months there is no order, the operational cost of the factory just goes on and on, whether we produce or we don't produce. So we have enough capacity. If you ask me, what is our capacity? We can easily produce 2.5 million packs of 90s a year, which is not a big amount. It's about 7 to 8% of the requirement in sub-Saharan Africa. So it easily can be manufactured. When we go to cost of manufacturing, as I mentioned, the biggest challenge is the linearity of orders. If you get ad hoc orders, it's difficult. If the orders are linear, we can definitely reduce the operational cost. However, there is no way we can meet exact price to price from an Indian manufacturer today because of the cost base. I think you Google any document, it will show you we are 6 to 7% more expensive in terms of manufacturing cost on the continent, plus the export incentives that certain governments give to their manufacturers. So if that was a level playing field, we are very, very easily able to manage to reach the reference pricing. Again, as I put a rider, sustainability of orders, and we need some sort of commitment in terms of approximate volume and linearity. Coming to API, I think, yes, there is drive towards API production in Africa. But
so thank you. I have to stop you in between because of time constraint. But you raised three very important points. One was on the basically pricing, the linear orders, basic quality checkups, and the capacity. I was very happy to note that you supplied it to 22 countries and there were no stock out. You could meet the requirement. But I'm not pretty sure what is the total requirement of African countries in terms of ARVs and how much can you supply and how you plan to basically scale it up. I think if you can just give me one reply, one half minute, 30 seconds, that would be helpful.
Yeah, I'll just work it out. So I think there is almost 20 billion patients on the treatment of HIV. We can cater today for about 600 to 700,000 patients out of that. Just a minute, let me just confirm that I'm right.
So we need more increase in the capacity of your corporation, and we also need to look into other countries. Other countries can really manufacture and go that level whereby WHO pre-qualified drugs can be manufactured and supplied. Because when portfolio is expanding, it has to expand beyond ARVs to TB medicines also, malaria medicines also. So
Exactly.
the beginning has been begin and very well done, and I think we need to expand it further. I'll move to community. Basically, I will go to Ms. Carol Lavina, who is a noted TB, HIV, and cervical cancer advocate and executive director of CTIM Plus. Carol, we'd like to know from you, or you have any concerns about the quality of these drugs? I'm raising this question because when India started manufacturing generic drugs way back in year 2002, 2003, there were issues about the concerns about the quality, but later on bioequivalence studies showed that they're as good as originators. So over to you regarding some specific concerns from the communities in terms of benefit as well as the challenges of local manufacturing. Over.
Thank you very much. Thank you for giving me this opportunity. So like you rightly said, in most cases when people start working on drugs, for example, the way you said about India, people have concerns. In Africa, we do have concerns, but not at that higher level because we know there are technologies that have been put in place and Africa is going to learn from India. For example, with UNITAID, for us, we know that there are partners that are supporting, because here I'm actually speaking on behalf of the communities delegation of the UNITAID board. I'm a board member there. So for us, we are looking at issues like the partnership between UNITAID and Africa CDC. We know that's going to help in the, like you said, in the quality of the medication. It is a vital step towards shifting power and capacity to the hands of the continent that continues to carry the larger burden of the global burden. For long, Africa has remained structurally dependent, as we all know, on external suppliers. But with the partnership, like we said, the memorandum of understanding, this signals a strong commitment to advancing health sovereignty through local manufacturing, which for us is important. As communities, as the recipients of care, it is important for us because we are the ones who are taking those medicines, and at the same time, we're the ones that need to create demand in the countries, as well as also pushing for the political will with our governments. We need to go back to our government to say it's important for us to get to support the Africa manufacturing so that it supports the gap that is there now. Like we heard from the previous speaker, he looked at the gap, which is quite big. So we need that support. And from the perspective of affected communities, like I said, again, this partnership for us, it holds a transformative potential, but only if it integrates access, equity, and inclusion throughout its implementation. And expanding regional manufacturing must go hand in hand with responsiveness to country priorities and the real needs of those who are affected. It's important that the real needs of those who are affected. And this includes people living with HIV, TB, hepatitis, as well as adolescent girls at risk of cervical cancer, and communities that still lack reliable access to medical oxygen and diagnostics, whether this be in rural areas or health posts or in urban areas. So for me, I wanted to say it is important to stress that increasing production alone will not ensure access. So in as much as we are going to worry about the quality of the medication as communities, for us, access is very important. Without parallel efforts to address regulatory procurement and pricing barriers, locally made products may still remain out of reach for the communities that need them. So again, I'll go back to the partnership. We believe it should prioritize investment in the regulatory harmonization and food procurement systems to create a potential demand. Again, I would like to urge UNITAID and Africa CDC to place us the community ownership at the core of its work. As communities, we are not just recipients of care. We are also implementers, advocates, and innovators. If this initiative is to be sustainable and impactful, it must institutionalize mechanism for meaningful community participation, particularly in decision making, in particular related to product selection, deployment, and scale up. This is especially critical in the context of pandemic preparedness and response, where community trust and engagement determine whether success or failure. So finally, I want to caution against a narrow flow of vertical disease programs. I've heard the other speakers mention on the integration. The partnership should promote integrated approaches that respond to multiple health challenges at once. Investment in diagnostics, supply chain, and health workforce development should be structured to serve broader systems. Only then can we build resilient public health infrastructure that delivers for everyone and everywhere. In closing, again, like I said, I'm speaking on behalf of the community's delegation. The community delegation stands ready to collaborate with UNITAID and Africa CDC to ensure that this partnership delivers on its promise. We are committed to ensuring that what is manufactured in Africa is also accessible, affordable, and equitably distributed to those who need it the most. So as the communities, we are willing, we are ready to create demand and to support and to ensure that what is produced in Africa is of good quality. I thank you.
Thank you, Carol. A very important point. You rightly said, and I would reiterate that increase in capacity does not mean increase in access. So we really need to facilitate access through overcoming regulatory barriers and strengthening the procurement systems. But definitely the quality issues are being taken care of if these are WHO pre-qualified drugs. So we really need to find ways whereby the regulatory processes are streamlined and countries don't find barriers in getting drugs, locally manufactured drugs. So moving ahead, we are already into 45 minutes of the session. So we have just 15 minutes left. And we move a little bit now away from HIV into TB. And we have Dr. Srinivas Nair, who is Senior Advisor in Stop TB Partnership. Hello, Dr. Srinivas. So, we know that Stop TB Partnership has supported the largest ever rollout of new TB. Particularly like in India, we know we have got TrueNet, which is Molbio's battery-operated substitute for CBNet, and it is the only molecular technology which has been deployed globally by Stop TB Partnership. And the Global Drug Facility has also made a major difference in ensuring this thing. But I have to know from you basically, how can the local manufacturing in the African countries will have a benefit on the TB program? Over.
Thank you, Rewari. It's great to be here and to discuss about this. Stop TB Partnership is always promoting the South-South collaboration, and we have systems. One of the important one is that how do we promote innovations is taking whatever the innovation is happening. We have a very high risk appetite as far as trying out with the innovations. Projects like TB Reach, when we encourage the local innovations, whether it is in the new tools or strategies, and take it up and try to do it in different countries. Because one of the biggest problems one of the blocks in the innovation sphere is that if it is done and successful in one place or one country, doesn't automatically means that the other country will take it up. We need to repeat that the same data and the same research need to be repeated. And sometimes it is very painstaking for the innovators to wait for ages to reach to the people, and also for the people, because ultimately any innovation, it need to reach the people at the earliest. So that is where TB Reach and later we have projects like new tool innovations, introduction of new tools projects. So through all these multiple projects, what we try to do is that innovations, wherever it is happening, have some data for it in multiple countries, and also try to get this WHO and other regulatory approvals, so that then it can be again funded through other mechanisms, including the global fund mechanisms, and scale it up throughout. So that is a general structure, and as you already mentioned, there are good examples of how the global South is leading in the innovations, not just about the tools, but also about the strategies, and we facilitate those one. The TrueNet is one example. The other one is the digital X-rays and the artificial intelligences, and all of this one, including the new drugs and regimens. There is this system of making it available to the people. I would put another aspects of it is again what is the global south leading in tuberculosis. We had seen in tuberculosis control, being very frank, in Stop TB partnership, we don't really mince words. So I'm actually not being diplomatic. The tuberculosis programs all over for many, many decades has been controlled, or I should say, by the policies of the global north and the resources of the global north. In the recent time, fortunately, that has changed. The global south has taken the leadership thanks to political commitment, of which has actually, we should say that it is started in India, and it is expanded to Philippines, Indonesia, Nigeria, Kenya, South Africa. All of them is taking up the TB control as a political priority. That led to a lot of innovations. What we are seeing in the drugs area, in HIV, a lot of the similar things are happening for the diagnosis, because for tuberculosis, point of care diagnosis and better screening tools, better screening strategies, and the policies to take the care to the people are more important. And so in TB, those things are happening. So the innovations are going beyond boundaries. We earlier we used to say the TB programs are in the boxes. You have got boxes, and everybody has to stay in the boxes. Those boundaries are being broken, and that is thanks to a lot of innovations which has happened in the South, and that has been expanded to the world. Community engagement and strengthen the community roles, addressing the stigma, the discriminations, and the human rights issues are a core area which Stop TB Partnership supports. And there also, this lessons learned and cross lessons learned across these countries are critical. Now, of course, the financing is, something like we keeps on talking about a challenge, but I would say that most of the high TB burden countries, it is the domestic funds which is driving the TB program, not international funding. However, there is some international funding in some countries which, recent drops have all created challenges. But there is a lot of innovative financing things which are also happening, whether it is, loan buy down or a debt swap. Also, there are smart ways of linking the diversifying the funding availability. For example, the climate funds, the pandemic funds, these are all can be used for a strengthened health system, and many countries in the global south are going in that direction. Just giving an example, having a handheld laboratory, like a laboratory in a suitcase like TrueNet, digital handheld digital X-rays with the AI, if it is available in the peripheral healthcare facilities in these countries, that can actually help not only TB, but it is a health system strengthening, multi-disease platforms, and community health system. Clubbing all of them together, we can actually pull in resources, and we are facilitating countries to access those additional resources to, make sure that, still TB doesn't have enough funding. We will always cry for more resources, but that is not alone. And so this is happening with African countries also. With Africa Development Bank, there are discussions happening. So ultimately, what we really need to look at, I will not go more into it, but I will restrict it by saying that it is that we have stopped, the global south has stopped listening to people from global north, unless that person has got all the global south experiences, and that is why he is speaking. So thank you, Rewari. Are we missing Rewari suddenly? If you are not there, I will continue, and then your time will be a big problem.
Yeah, I think Dr. Rewari's internet could be an issue perhaps. Well, anyways, was thanks a lot, Dr. Nair. This was really so important, and especially for the courage with which you have shared. This is really important to to not to say things as they are, and without which we will never be able to address the inequity and injustices. So thanks a lot for your insight. Moving ahead, I think I will invite Mr. Sumit Mitra. Mr. Sumit Mitra is the President International Sales at Molbio Diagnostics, and a strong voice for ending inequities in health. Sumit, are you there?
Yeah, hi, Bobby. I'm there. Can you hear me?
Yes, over to you.
So thank you very much for this opportunity, both Bobby and Shobha. I will actually like to start off where Srinivas left, that the Global South is no longer going to be listening to the Global North, but we can always offer free trade agreements to the Global North to start North-South collaborations if they want to. Jokes apart, I will want to kind of just dwell on two aspects. One, of course, most of the earlier speakers already spoken eloquently, and our own CMO, Dr. Sachdeva, has kind of put the ball rolling. As far as Molbio is concerned, we have been part of Stop TB, GDF, Global Fund, United Nations in terms of providing unique solutions to the last mile. As Mr. Srinivas was saying, that you cannot imagine the impact of the solutions in those boxes when they become available to communities at the last mile. And more so when those boxes are enabling you to create a essential health infra and not just limiting you to one or two diseases alone. So that having been said, that is part of the process of taking services to the communities. We are also actively working with the communities so that they serve as implementers and they start demanding better quality diagnostics for their communities with the powers that be. Long story short, most of you are aware of the TrueNat story. I will not dwell too much on it, but 13 years has been our learning of what it takes from a company in the global south, from the emerging markets, as some would call it, or from the developing world, as others would put it, to really make global impact. And in taking south to south partnerships, we said, what we have gone through over the last 13 years need the other companies, the other innovators from Global South also go through the same process. And we said a vehement no. With that, I would like to introduce all of you to something that is in the second year of its implementation. It is a program called the EDGE. I will repeat. It's a program called the EDGE, which was started by Molbio, and it's R&D arm, Big Tech, last year, wherein we invite applications from all medtech startups. And last year we had because it was our initial year, we had done it only for companies from India, but Edge 2, for which the applications have probably just closed out on the 15th of last month, has been a global call. So what it is going to do, it's going to be an intensive 12-week cohort program for understanding high-impact technology acceleration and faster go-to-market traction. At the end of this program, Molbio would engage with a few cohort participants for future partnerships. This would potentially involve bridge funding for product co-development, licensing, sales, and distribution. Each cohort participant will receive bespoke guidance. The program will be conducted both in Bangalore and Goa, for which Molbio will foot all the bills. So I think this is very, very important. I know I'm sure there would have been other examples in the pharmaceutical world. I'm not aware because my own experience has only been with diagnostics. to think of enabling other partnerships, other developers, other innovators, which otherwise we would look at as competition, but not looking at them as competition, but to allow them to gain from the benefit and the experiences that you have yourselves gone through, so that the experience of all those journey for the newcomers are not that elongated. And as somebody said, it is much, much important to take diagnostics, quality diagnostics, as soon as possible to the market. So others need not waste so much time in learning about regulatory processes, in learning about how to scale up, etc. So I thought from the Molbio perspectives, because all that Dr. Nair, Dr. Sachdeva, and everybody else has said about TrueNat is perhaps well known, I think this is something that I wanted to share in this particular important discussion as something probably which is unique, that one manufacturing company which has gone through the gamut of all these processes is now acting as an enabler for all other startup companies, so that they can learn from these experiences and accelerate their advances towards the products that they are developing. So, Bobby, I think from my end for this particular afternoon, this was the most important piece that I wanted to share with all of you. I will pause here and I'll be very, very happy to take questions at the end of the program. Thank you very much.
Mr. Sumit Mitra. Sorry that my connection got disconnected and rejoined. I could listen to part of your deliberation, basically. But if I look at the available information, you have exported now this TrueNet to over 90 countries in the region.
That is correct.
South,
Yes.
yeah. So that is very heartening to see how India is basically expanding in areas in Make in India kind of initiative. But my concern was, okay, you may be in 90 countries, but what percentage of requirement are you covering, and what is the plan for a faster rollout? So that I know it depends on the demand, people asking for it, but then you have to advocacy and other things. So what are your plans that you can roll out these faster on a larger scale, I mean to say, over very quickly?
So, Dr. Rewari, I will respond to this question by one simple sentence. Our current manufacturing capacity for the TrueNat tests is 350,000 a day. And at the moment, we are not even probably utilizing 15 to 20% of that capacity. So we are, in terms of the capacity, it is already there. But having said that, we do have the bandwidth to kind of scale up even further. And as you rightly said, this will be completely dependent on the linearity of the orders that we get. But with all the LTAs with Stop TB Global Fund and the United Nations in place, we are sure that this is going to ramp up sooner than later. I hope to have responded.
I think, yes, you have responded. You have the capacity, but we really need to work further with Global Fund, with UNAIDS, other agencies, community, and with the governments, basically, if we really want to move it faster. We have the tools, but we need to put it adequately across the country so that we can really utilize their benefit fully. Just going back to Srinivas, you are there, Srinivas? It timed out my connection.
Oh, yes.
Yeah. So my question to you was basically about the global drug facility. We know this has been a great example of maintaining the drugs over the time to the countries. But do you think, can we have a mechanism which brings in drugs manufactured within Africa and have, because I know the global drug facility will have now some challenges on funding. That is my one question. Second is on very quickly on the newer drugs, bedaquiline and other drugs, basically. What are your plans? So 30 seconds, please, each.
Yeah, the quick answer is yes. In fact, Global Drug Facility is taking drugs from pre-qualified or ERP, approved manufacturers from Africa and also other countries. Yeah, the truth is that majority of the drugs are coming from anti-TB drugs are also from India, and some from the European countries and some from US, especially some of the newer drugs. But yes. Recently, we had some, newer manufacturers entering into the GTF catalog from Africa and also from countries like Pakistan. So some of those drugs are there. So there is a continuous effort for doing this. But as you know, that the GTF, we maintain these two things. One is about the quality assurance, either WHO pre-qualification or an empowered review panel that need to be there. The second one is it's a competitive platform, right? The tenders are being plotted, global tenders are being plotted, and so you should have the quality as well as the right prices for it. So that is the system which is existing now. Second, as far as the newer drugs, we are also, the drugs are available, the BPAL regimen, which is actually radically changing the way the drugs-assisted tuberculosis is being managed, and these drugs are available and the countries are, and probably I should say that this is one of the largest expansion or the quickest expansion of a new regimen which is happening is the BPAL-M, because it's a 6 months regimen, all oral regimens. The side effects are, there is, I think it's a communication, and along with the UNAIDS funding, Stop TB Partnership is starting a new community based, demand generation project soon. It has actually launched recently, and this is there in 5 countries, that is India, Pakistan, Cameroon, and DRC, and Moldova. These 5 countries we are implementing it along with some of our partners, and there are under the same UNAIDS project there are a few other projects are also going it, and they are working together, because ultimately we will discuss later in the sessions also. It is the community's demand generation is very important, and the communities need to demand the best care, and then of course they need to do the community monitoring also and community support also. So when all this comes together, so this particular project is to support those communities for demand generation, for community-led monitoring, and also for the supporting the peer support using the TB survivors and TB champions in all these countries. So this is another area where we are providing support.
Thank you, Srinivas. So move on to the last panelist of this session. We are close to the time also, but we have a very important part on this basically, which is largely, I will say, well known now for tuberculosis. Basically, when we talk of basically AI, but I know that Mr. Ajit Patel, this is being utilized now specifically for chest X-ray interpretation, but we know that now Genki AI screens for 26 pathologies, which include TB, pneumonia, and other. So what are your plans basically that are you going to move further into other pathogens other than TB also, and or there is going to be missed over to you.
Yes, no, thanks, Dr. Rewari. Thanks a lot for the question. But I just wanted to take a pause and take the opportunity to thank the Molbio team. I think Mr. Sumit Mishra mentioned about supporting other companies who are joining the global health space anew. And I'm one such company. I'm lucky to be in India and have been very lucky to have strong support from Molbio team. So I really want to thank about that. And I think Dr. Srinivas also talked about how technology innovation is transforming, making healthcare more accessible and affordable. And that's one part of the journey which we are walking in. So Dr. Rewari, I just wanted to touch upon your question, but also share a brief presentation if you allow me to. And I'll take a few minutes only.
We have 3 minutes only for you. Sorry.
3 minutes. Absolutely. No,
3
no,
minutes.
not take
And you
much
have
time.
19 slides. I don't think that's possible.
No,
You
no,
can
it's very
focus on
short.
the key slides. Yeah.
Correct, correct. No, no, absolutely, absolutely. As I said, a bit new to the healthcare public health ecosystem. Great help from all of you. Thanks a lot for that support. And currently, we are supporting almost 500 hospitals and imaging centers. We have more than 325 public health screening sites globally. And I want to share some of our experiences. But at the core, we have the chest X-ray AI solution, which automatically analyzes the chest X-ray, identify almost 21 plus conditions on the chest. We have the US FDA, we have the C certification. Importantly, we did the WHO PQ recently, so we have WHO recommendation also now. The outcomes have been amazing. We today support more than 325 TB screening sites across India. We have sites in Asia Pacific, Philippines, in Africa, and quite a few other regions as well. But I think India has been the forte for us, the prime forte, and we have seen some amazing outcomes. I would like to talk about some of the outcomes we have enabled, and would like to dive into the case study we have in Tamil Nadu, where we have screened more than 500,000 people. And what we have seen is we have seen almost doubling the yield of TB patients. So in districts in Tamil Nadu, where AI is not being used for TB screening, we see almost half of that where AI is being used. And as a result, we see the cost of identifying one TB patient is almost half when AI is being used. And more importantly, we see an impact on quality of life, because through chest X-ray AI, we are able to find patients who are subclinical, who don't have symptoms, and hence the impact of medication on them is better, and hence the impact on quality of life is substantially improved. There have been a lot of learnings, though. I think I want to touch upon learnings because AI is still new. And one of the key learnings is that the same AI product, when used in different cohorts, for example, different machines or different ethnicities or age groups and genders, you'll have different accuracies. And what you can see here is across different districts in Tamil Nadu, we see a slightly different accuracy numbers, though the overall accuracy numbers are fairly high, 92, 82% sensitivity specificity. There is a small variance across different districts, and our solution helps you identify that automatically, helps you identify variance across age groups, BMI characteristic, genders, and all. And that's what is called as responsible AI. That's one of the key innovations we have brought in, that through using our platform, we automatically compare the AI outcomes with the sputum results and the radiology reviews. And we kind of help you identify what's the real efficacy of AI at your given setting and help you tune the AI for your specific setting. And one good marquee example we have is Singapore government adopting us at a national level across all the public hospitals, where we have delivered some amazing outcomes. So that's a very quick overview, I think. But coming back to your question, Dr. Rewari, the intent is far more. TB is one important use case, but lung nodules, for example, early detection of patients with cancer, potential cancer issues. Silicosis is one use case which is being looked at very carefully now. And eventually pollution-related emphysema and other conditions are the areas which we are going to focus on as we move ahead.
Very interesting presentation. Would have loved to listen to whole, because this is the area where we have very little information, Mr. Patel, and would be great if you can share the presentation in the chat box. People may like to have little more information on this. Well, we had a great people in this session. As a chair, sometimes I feel that my job is basically to stop others, to keep yourself to the time, but that is also essential part. And in that, it offers very little time for the chair himself to express his, share his experience and opinion on others. But I think I've been able to get to you after your deliberation on some of the questions which have been answered very well. I would like to congratulate Bobby, Shobha, and other partners for this wonderful session. Basically, I know your next session is getting delayed, but it was a great opportunity to listen that how basically Global South is being strengthened now, with not only with the manufacturers, but also the Global Fund, UNITAID coming in. UCL is leading the way, but there is a long way ahead when we basically talk that we are going to strengthen. We know that when we talk of HIV, hepatitis, or TB, or a malaria response, basically our continued investment helps in strengthening the health system. It is very important that health systems are strengthened ultimately, and we have seen some of the examples in today's discussion also, because it is not only manufacturing ARVs, it is basically conserving your foreign currencies, local trade, local employment, reducing the cost while maintaining the quality. Focusing on quality also leads to that kind of help in other areas also. And this also basically address promoting the community-led initiative and community-led monitoring. I know that community has been always a very important part in our response in HIV, particularly reducing new infections, treatment literacy, and other areas. So this was a very wonderful session, and I would like to close it here unless there are some other burning remarks from anyone in 1 minute, and hand over to Shobha after that. So I don't see any other question or response. So over to organizers. Thank you very much for giving me this opportunity.
Thank you, Dr. Rewari, for your impeccable chairing of the panel discussion. So you made the most of the time, and thanks for sticking to the time so well. And thanks to all the panelists also for their remarkable insights. We now move on to another exciting panel discussion on successes, challenges, and possible solutions for community-led and person-centered TB and HIV responses on the ground. The chair for this panel is our dear friend Subrat Mohanty, Stop TB Partnership Board Member and Health Programs Coordinator at Humana People to People India. Over to you, Subrat.
Thank you, Shobha, and very good morning, afternoon, evening to everyone, wherever you are. Shobha, thank you for giving this opportunity, and to Bobby also. So as Shobha said, my name is Subrat Mohanty, and I'm really honored to chair this important panel on community-led and person-centered responses to TB and HIV. I was listening, Shobha, very carefully, the panel one session, and I heard Dr. Srinivas, even Sumit and Ajit and everyone talking about community engagement, how we can blend the community engagement into all the other areas, which was really important. Around the world, it's become very clear, communities are not just beneficiaries. They are essential partners in ending TB and HIV. And we all know that how the HIV movement started way back in 2002, 3, 4. And we have people like Manoj and Daksha, they are here, who has seen, all of them have seen the HIV movement and how community really played an important role in moving everything on HIV moving forward. And the community are the first to respond, the most persistent in outreach. Even we have seen in during the time of COVID, how the community, they have reached out to people to serve them and to provide medicine and everything. And often the last line of support when the system failed. Today we are joined by very inspiring individuals. I'm so fortunate, so lucky to have these panel members whom I know, most of them I know very well. I've worked with them. I know the extensive work they are doing with the community. They are the leaders with lived experience and powerful insight, who will speak to what's working, what is not working, and what need to be changed. So I would request this panel discussion or the panel member to let's keep the discussion honest, focused, and solutions oriented. Here we are not just sharing stories. Stories are good, but here we are not just sharing stories. We are shaping what effective, dignified, and inclusive community systems should look like. We have the, I don't know, Shobha, can you just check if Timur has joined?
I will just check and let you know. I don't think he's there as yet.
Not yet.
Not yet?
No.
Okay. So with that, I would like to warmly welcome all our panelists. I hope Timur will join soon. And we have all other members who have joined. And I would like to invite first Teriro. See, actually this is an opportunity for me to call them name, the first name, because I know them well. So Teriro from the Zimbabwe, the TB people Zimbabwe, and Teriro being a very strong activist for HIV and TB. Teriro also being a member of the Union Community Advisory Board. So Teriro, this is something I just wanted to ask you, and we all would like to listen from you, that the community-led person-centered TB and HIV responses. How do you see all this big word about community-led person-centered TB and HIV responses and how it is working on the ground? Over to you, Terino.
Okay, thank you so much, Subrat, and thank you, the organizers, for this side event. When we look at community-led monitoring as communities living with the diseases and civil society, we see it as one of our success story. It is one of our success stories in the improvement of TB and HIV response. It is putting the communities at the center, though it has got some flaws here and there, but for now, when we say success story, this is one of our success story because communities are able to monitor significantly at their levels what is affecting them, and it has increased access to services, reducing waiting times, decrease the stockouts in some cases of medicines. Such approaches also led to higher rates of HIV testing and viral suppression, demonstrating the power of community engagement in driving really change. So I can stop here because I know we are many of us, but it's one of our success story as communities. I thank you.
Yeah. Yeah, thank you, Tarido. And yes, community-led monitoring has been very effective on the ground, and we have seen the results across so many countries in terms of tuberculosis. But Tarido, again, going back to my second question, you know, Zimbabwe, you are from Zimbabwe, and
yes,
Zimbabwe has a strong tradition of activism in health. How have you seen person-centered approach shift the power dynamics in TB and HIV care?
Come again?
No, I'm saying that how have you seen as a person the person-centered approach shift the power dynamics in TB and HIV?
Okay, thank you so much. While we always talk about patient-centered approach and so forth, yeah, it is a very good approach and it is working. As I said, through community-led monitoring, to say it's the people who do all this monitoring, who do all the taking up of information on the ground, synthesizing it with the technical partners and so forth. But again, as much as we are saying that there's one biggest challenge, the challenges which is a stigma and fragmented services. While we are well organized as communities, while we have got structures, while we have representation at every level and so forth, but our Ministry of Health and other services, they are fragmented. And we are supposed to integrate them and so forth. And stigma. And I'm going to applaud WHO for bringing up the isolation, connection agenda, I think yesterday. Stigma is, we just talk about it. It's a real. People are isolated and so forth. So this fragmentation of services is a barrier to our patient-centered approach, which is a very good approach. Stigma remain a major barrier, and people with TB and HIV, especially those from marginalized groups, often face judgment, exclusion in health facilities. So once you're excluded from the facility, where is the patient-centeredness in it, which leads to delayed diagnosis, poor treatment adherence, and worse health outcomes. Additional TB and HIV services are often fragmented, forcing people to navigate multiple clinics with further discouraged care and seeking. And once you navigate to different clinics, obviously there are some catastrophic fees that comes with it. And it is a good strategy, and we should bank on it, but also there's need to look beyond just patient-centered. Let's look, this persistent challenge of stigma and fragmented services should also be put as a great agenda. Thank you.
Thank you, Tarino, and I also agree with you. Stigma is one of the major barrier everywhere, and normally we think that in TB there are no stigma, but we have seen how stigma has affected families and also in treatment adherence and everything. But again, my last and small question, because Tario, we have to be very specific now. So when you're talking of stigma, what role have women and in particular young people have played to address stigma?
Okay, thank you so much. As Minister of Health and the partners and civil society and the community space, I think most countries come up with the documents that help us to tackle stigma and discrimination at different levels, what pushes it, and what are the percentages. Remember, without evidence, things are you cannot come to a platform. So we are doing this, and we applaud Stop the Partnership for helping countries, partners to come out of the stigma index. And that stigma index, it is our evidence to help us to respond to stigma reduction. And the possibility solutions on that is, once we integrate integration of services and tackling of stigma is put together, then we can get somewhere. So I can say solution could include integration TB and HIV services for seamless person-centered care and institutionalizing community-led monitoring and advocacy. Crucial, tackling stigma requires health worker training as well. Not only the person, the people living with the diseases, and community education and policies that promote respect and inclusion. Empowering affected community to participate in decision making, ensure services are responsive, accessible, and stigma-free. So together, if we work together from ministry, everyone, we can reduce stigma, but it needs integrated of TB and HIV services and person-centered, as we have tackled it, to say that is the core of how we can possibly deal with these challenges which are impeding the results, the outcomes of ending HIV and TB pandemics.
Thank you, Tarino, for all these answers. And you know, we all have to work together to see that while you're talking of ending TB, the issues like stigma, discrimination, human rights, around TB also need to be addressed. So thank you so much, Tarino, for your answers. Moving to the second panel member, Norman. Norman is from Botswana, and he is leading the TB People Botswana. Norman, for the question for you is, are you there, Norman? Shobha, can you please check if Norman is there? Hello?
Hello, yes, we are checking. I think he was here, but I think isn't maybe due to internet he's no longer. But we are following up. Meantime, you can move ahead. Yeah.
Okay, shall I move to the next one and Bobby?
Yes, please. Yes.
Okay, so Norman can come back as the next speaker. So now moving to the other speaker, TB People Uganda. And Michael. Michael,
yes,
you. Hi, Michael.
I'm good. How are you doing?
Okay. Michael, you have seen the community engagement in your country, Uganda. You have seen the country, how they have moved in the time of HIV and also in TB.
Hello, I'm sorry, Subrat. Can I interrupt, please? Yeah.
Yeah, please.
Yeah, I think we will come back to Michael. Michael, just hold on for a few more minutes. And I will pass it on to Shobha to request Dr. Urvashi Singh. She's right here.
Okay.
So it will be wonderful for us to listen to her because a huge difference has been made in India under her leadership of the Central TB Division. Shobha, over to you. Hello. Hello, good morning, ma'am. Sorry, good afternoon, ma'am. Are you here? Dr. Urvashi? Shobha, we can't see you, please.
Yes, sorry. Hello.
Yeah. So Dr. Urvashi is here. So
yes.
yeah, okay.
Yes, Dr. Urvashi is there, and we are really honored to welcome Dr. Urvashi Singh. And Subrat, we will please give a pause to the panel discussion because Dr. Urvashi has just, I think she has just left some meeting and come here to speak with us. She's a noted researcher and head of India's National TB Elimination Program. And she is DDG Central TB Division, Ministry of Health and Family Welfare, Government of India, and former in charge TB and professor Department of Microbiology at the All India Institute of Medical Sciences, Delhi. And under her leadership, we have seen how in-country competencies and capacities can make a defining difference in public health. The first country in the world to screen everyone for TB in high-risk settings, regardless of TB symptoms, has been India. Thank you, Doctor, for following the science and ensuring that National TB Elimination Program is rooted in science and evidence and is also person-centered. Over to you, ma'am.
Thank you so much, Shobhaji, Bobbyji, and I can see Subratji and the other participants. A very good afternoon and good morning to our friends from the rest of the world, and good evening to those from the eastern side of the globe. So thank you for the kind word, Shobhaji. The essence of all that we do comes from our commitment to take care of our patients. So, as traditionally, TB was, screened based on symptoms. As new knowledge, and like Shobhaji just said, as scientific evidence accumulated, we became wiser. So I would like to give a simile of COVID. When COVID-19 first came, nobody ever believed that while the patient would be asymptomatic, that is pre-disease, during the incubation period, the patient can transmit the disease. Similar is the problem with TB. We never thought that if the patient has no symptoms, there could be a disease, there could be a component of subclinical TB. This evidence came in about 10 years or a little more than that earlier on. And most of the medical community did not pay heed. While we did some research, while I was, I still am a professor at AIMS, Delhi, we published a research where those who were, immune compromised groups, like type 1 diabetes patients who had no symptoms, we screened them using cultures, and they grew TB in about 15% of the patients we screened. This and more global evidence guided us to enhance our screening. Also, the prevalence survey in the country, ascribed in our country in India, got published in 2022. This was an effort of the National TB Program under the ministry, along with ICMR, who's part of the ministry, where we were able to show that asymptomatic or those with very mild symptoms and those in high risk groups like diabetics, people living with HIV, smokers, alcoholics, those who had BMI less than 18.5, those who were geriatric population, and those with TB in the past and those in contact with TB patients. These 8 groups primarily, along with congregate settings and communities which are involved in mining, and there's more dust exposure in urban slums, in professions like tea gardens. um, their presentation could be, they may be asymptomatic, they could have subclinical TB. Hence, what we decided as a new strategy for the National TB Program was to offer screening to all these risk groups who are more likely to break down to TB, either due to their immune response being not up to the mark, or because they are residing in communities where transmission could be higher, and patients who are asymptomatic could also transmit. We decided to take this as the strategy, and we have been able to roll it out across the country. And let me share with you our experience. It started as a 100-day campaign on 7th of December, launched by our Honorable Health and Family Minister under the vision of our Honorable Prime Minister. In India, we have had this support from the highest office, and the program continues to support. In fact, one very major highlight in our country is that the budget is primarily domestic budget, and this has been acknowledged by the Global TB Report last year, that the support financial is all thanks to the government, who takes care of any expansion of the activities as well. So the 100-day campaign proved to be an eye-opener. We were screening all vulnerable groups in high-risk districts where the incidence was high, where mortality due to TB was high. We were able to screen close to 13 crore population, which would be 130 million population. And we were able to find close to 3 lakh asymptomatic individuals who would have remained undetected till they had overt symptoms, till they sought care in a healthcare setting, only when they broke down to frank TB with symptoms. By the time they had this breakdown, they would have infected more in their contact, in their immediate family, in their workplaces, during their commute. So, this was a change in strategy which brought in a large number of asymptomatic vulnerables who got due care, and who got, so in our country, in addition to free diagnostics, free drugs, we also support for the sake of nutrition, so which again has been enhanced since I took over. We enhanced the direct benefit transfer, which is under the Nikshay Poshan Yojana, which was earlier in 2018, again, a visionary leadership, ensured 500 rupees per month support to all TB patients. This amount was enhanced to 1,000 rupees per month to all TB patients throughout their treatment course. In addition, we were supporting through food baskets, one food basket every month to all TB patients who would consent to receiving a food basket. This food basket was enhanced to the families of the TB patients as well. So, undernourishment does not lead to the breakdown of TB in those who are exposed as a household contact. Also, since in our country, what we realized was low BMI, less than 18.5, was contributing to the tune of about 46% of our TB patients. What we have rolled out, again, science-based, scientific evidence-based guideline, is an energy-dense nutrition support for all those with BMI less than 18.5 for the first 2 months at least. Now, these have been the nutrition support that are being offered consistently. We have a state-of-art digital portal where all our TB patients are reported, are followed. This is called the NICSHARE portal, which is a huge digital portal, and even our peripheral workers, like our ASHA workers in the village, that is the last mile, are able to notify a TB patient on the digital portal. The details of the patients are, of course, kept confidential. Only those healthcare workers with access to the NICSHARE portal can access and ensure. So this digital portal also enables us to give complete treatment, monitor the treatment, ensure treatment adherence, ensure post-treatment follow-ups. So in the program, we religiously take care, one, of early diagnosis. So our effort towards screening the vulnerable population was also to ensure early diagnosis, early treatment of initiation, and this way we could also ensure reduction in mortality, because if you're diagnosing TB early in a comorbid patient, somebody who has a comorbidity which predisposes him to the disease, such patients could also benefit from early diagnosis, early treatment initiation, and early cure of tuberculosis, which would then not complicate the comorbid condition, and hence, a dip in the mortality can also be observed. So coming back to the 100-day campaign, what we use for screening is the WHO recommended methodology with the best sensitivity, that is the X-ray. During the 100-day campaign, since this was the strategy adopted, the X-rays were offered as a screening tool to those who were even asymptomatic. I talked about this earlier. And when they had any abnormal shadows on the X-ray, they were offered the nucleic acid amplification test. We in our country worked on an indigenous tool within the country. So though we had adopted the Gene Expert system since 2013 into the program, we were able to expand to more than 9,200 NAT systems across the country. This is a wonderful network, and the National TB program enables external quality assurance for all the NAT sites. This was enabled by bringing in TrueNat, which was found to be at par with the Gene Expert system, and the WHO has also recommended TrueNat. We have been able to have more than 1 crore NAT tests in the last year itself, and this year we hope to cover more, because with enhanced screening, the campaign, which was originally rolled out in 455 districts, 347 which were high burden, high incidence, high mortality. In addition, the states which wanted to enhance the campaign coverage to more districts brought in more districts. But from the date of the TB Day this year, the World TB Day, 24th March, the campaign has been expanded to cover all districts across the country, and we are working hard in the implementation of the campaign across the country, in the monitoring of the campaign activities across the country. During this period, we have been able to enhance the capacity of handheld X-rays for screening. Across the country, we have more than 500 handheld X-rays. As we speak, several states are procuring more handheld X-rays, and the central team, that is the Central TB Division at the National TB Program, we are procuring close to 1,500 more handheld X-rays, which will be provided Two are far-flung areas, are difficult-to-reach areas, are tribal areas, are mining areas, and we will ensure that soon all our CHCs will be saturated with handheld X-rays. During the campaign, we were able to have health camps, which we called Nikshay Shivers, all across our campaign district. So, mobile medical unit, which was equipped both with X-ray and a NAT, would hold camps in different sites. The Ayushman Arogya Mandirs, which are our peripheral outreach healthcare facilities, were able to organize health camps with support from the CHCs, from CHOs, our ASHA workers, our district level teams, our block level teams. They all got together and had a micro plan in place. So these health camps were held across Ayushman Arogya Mandirs and the mobile medical units, where there was a planned route and camps were held all over. We made line lists of the vulnerable populations I enlisted earlier, and these line lists were offered a screening by X-ray, and an annual screening going forth was also recommended as a follow-up exercise. Now, all this activity, like I mentioned earlier, gave us, we were able to detect several asymptomatic vulnerables, and they were offered all support that a patient of TB is offered. As far as community engagement and our effort towards having a TB champions on board, India is one country where we can boast that we are actually honored to have our TB survivors, our TB champions, to serve the community with support from the National TB program in a big way. We not only offer them training to support a TB patient, but having them on board, we are honored to have them with us to serve our current TB patients, handhold them, guide them through side effects due to antitubercular treatment, ensure that the TB patients complete the treatment, and tide over any side effects by referring them for a follow-up to a healthcare physician, but also encourage them, because whatever said and done, stigma is one deterrent that keeps the TB patients from coming forth to seek care, to complete treatment, because they're afraid of being outcast. So TB champions is one strength which India treasures, who are able to help us help the patients tide over the difficult times. We have also had TB champions support us in our rollout of BPAL M regimen, which we rolled out very carefully. Again, this was an initiative of India, which several countries are now wanting to emulate. We have rolled out not only BPAL, but we have added moxifloxacin to patients with FQ resistance based on the TB practical and other global evidence. And in this rollout, we have carefully rolled it out. We are monitoring all patients carefully for any adverse effects. We have a weekly follow-up. Our CHOs and ASHA workers have been asked to visit all TB patients, not only DRTB patients. The CHO has been instructed by the highest office to visit every 15 days. The ASHA workers have been asked to visit the patient every week. During the BPAL-M rollout, what we ensured was that every patient is assigned not only a senior treatment supervisors and a TB health visitor, but we have also tried to ensure that they also have a TB champion who is following up whether the patient takes the drugs in time, whether there's nutrition support, the patient is taking adequate nutrition, and the healthcare workers are carefully monitoring and reporting to the Central TB Division on weekly basis whether the patient is gaining weight, whether his adherence to treatment is good, whether he has any adverse effects, whether there was any reason for him to discontinue treatment, whether he's been asked to change the treatment. So this monitoring is being done from my office on a regular basis. So we will ensure that all these patients who've been put on the BPAL-M regimen come out victorious. They get cured within 6 months with the efficacious treatment BPAL-M, which is fewer drugs, and we have in-country evidence to show that this is a wonderful regimen, and we will soon ensure that all our MDR TB patients who can fit into the inclusion-exclusion criteria laid down by the guidelines developed by the Central TB Division, by us painstakingly with experts from all over the country contributing. These guidelines are being followed, and we want to ensure all those who can get the benefit of the BPAL-M regimen do get the benefit. There have been several other initiatives on our part. We have been, working hard to get our panchayats, which is the village level unit, to get TB mukt, that is TB free. We have been ensuring reporting from all TB panchayats, and this last TB day, we were able to declare more than 46,000 panchayats TB free. We are moving towards the concept of TB mukt towns, TB free towns, and further, and encouraging our districts to move forward in this area. Another aspect I would like to highlight is the commitment at the level of the political leaders, which I alluded to earlier, not only at the highest office, but all ministries. We have had interministerial ministries, interministerials, MOUs, where all the ministries, line ministries, have been able to support us, not only to create awareness, but also in screening their own workers. We have a policy of TB-free workplace, TB-free workforce, and we are indebted to our sister ministries who have supported us not only at the center but also at the peripheral. Their peripheral officers have also supported the TB program in a big way. It's not only an MOU on the paper, but it has been actually seen that they have supported us throughout. We have support from our industries in a big way. The industries and the corporates have contributed to the corporate through the corporate social responsibility to our Nikshay Mitra initiative in a big way. We have support from the FICCI, the CII, the ASSOCHAM. Our own PSUs, public sector units, have been contributing to the Nikshay Mitra initiative. And we are actually thankful so what we called for is a Jan Bhagidari campaign, where we wanted everybody to rope in their efforts to support the national TB elimination goal. And we are proud to say that everybody has contributed more than their capability. So this Jan Bhagidari has been rolled out with support from all ministries, all communities, all our champions all over. It's a whole of government approach and whole of community approach. So with these words, I think I may be exceeding the time limit allotted to me, but I will be available for any further questions. So thank you for the patient hearing to all the audience and to the organizers, and a special thanks to Shobha ji, Bobby ji, and Subrat ji. Thank you.
Thank you very much, Dr. Urvashi. We couldn't see your face. I think your...
Oh, my apologies. I forgot to switch on the video, and I think there's some issue. I'm sorry.
No, that's all right. I didn't want to interrupt you. And thanks for sharing India's story and its NTB campaign. And I'm sure that can be replicated in other countries of the global south as well. And as you rightly said, political commitment is so very essential and integral for the success of any public health program. So it is the political commitment along with what you say, Jan Bhagidari, community participation. Thank you very much. We go back to our panel discussion. Subrat, over to you.
Yeah, thank you so much, Shobha, and always good to listen from the National TB Program Manager what is happening in India in the context of screening, diagnosis, community engagement, and everything. So now going back again to our panel discussion, and Michael I hope you are there, Michael. Yeah, thank you so much. Thank you so much. And Michael, to start with, can you share an example where a community-led initiative directly influenced national TB or HIV policy in Uganda?
Our community-centered approach in Uganda for TB and HIV have shown success.
Michael, can you be a little bit louder?
Access to like community-led person and centered approach in Uganda for TB and HIV have shown success in expanding access to treatment and testing, particularly among a marginalized population. However, challenges still persist, including stigma, inadequate funding, and difficulties in reaching key population. So this is the challenges that we are mainly pointing out: stigma, inadequate funding. Lastly, we had the UNAIDS on board. It was a huge support that it used to help people. I personally have been a victim with MDR at Murago facilities, whereby we used to get support from UNAIDS. And for now, on how the system is, we used to get some support from the organization. They used to give us some hope and support. It would have been money or to support us through the medication journey. But now, last time when we made a visit to the Mulago facility, we didn't find this support in the country. So we are missing out that support that used to give hope to the people, the targeted one, I mean those people on treatment. So now that also affects and it's a challenge. I don't know how we're going to do it. So here I would like to call, maybe it would have been the government to overtake this, keep on that support ongoing. Solutions to this, difference in community championship, like ownership. It would have been the community to feel inclusive to this so that we can make it out of this. Another bullet to the solution, improving data utilization and addressing systematic barriers through multi-sectional collaborations, organizations to come in and help us overcome these barriers. For now, I think that's enough. Got in time.
So thank you, Michael, for all the responses, and I understand how you all have saved the TB and HIV scenario in your country. But Michael, you also you are also a TB champion. You are a TB advocate, and you are with the TB in Uganda. Can someone please mute? Yeah. So Michael, from your experience, how people with HIV and TB have saved the Uganda's response to the TB and HIV? What has really played well in your country, where the community mobilized and you all are shown as a lived experience?
In community-led person. So here we have been having help with the village health team, the VHTs. They've helped us in tracing the victims so that we can look for a way for them to access treatment. So it has been their role, and mostly the organizations, other organizations, like recently, we have been having support from TB People Global. They have been a great partnership. So we have made to achieve this, or maybe finding tracing out to test and treatment. So they have helped us mostly in that, the TB organizations.
Yeah, thank you, Michael.
And also,
yeah, go ahead, Michael, go ahead.
Stop. We had also Stop partnership. Those guys have been doing great work, and it would have been also USAID, but for now USAID is nowhere to be found. We are really missing their partnership and help that they have been giving us to achieve the targeted goals.
That's very, very important, Michael. And again, when I listen to you and listen to Tariro, on the similar line about the stigma and discrimination and related issues, when you all being TB champions, you all are in the global TB people, and how you are actually addressing all these issues as a TB champion in your country.
With TB, what's a TB and HIV? TB is like everybody's a victim. So what we would have done this, it would just to sensitize the world to know what it means. This will help us. This will help us to achieve what we need. Teach another, teach another to avoid that. And with support from government, we are achieving. And by the time I know we shall reach the target.
Okay. So thank you, Michael, for all the responses. And I will revert back to you for if there are any other questions. But can I move to now Norman? Norman, are you available, Norman? Shobha, can you check if Norman is there or not?
No, his internet, he's having some internet issues. Yeah. Please move on to Jahangir.
Okay. So let me go to the next panel member, Jahangir. Jahangir also is my colleague at Humana, People to People India. And Jahangir is managing the program. He is implementing, he has been implementing the TB initiative in various parts of the country, including Delhi. And Jahangir, you also is like a force behind the urban, addressing the TB situation in the urban slum. So Jahangir, with all your experiences in working with the vulnerable and marginalized population in Delhi, how do you see that addressing the issue of stigma, addressing the issue of discrimination, addressing the issue of risk population in your in the implementation of urban TB model?
Okay, thank you. Thank you, Shobha sir. And good morning, good afternoon, and good evening to all participants. And also a special thank you to CNS team for inviting me for this panel discussion. I'm happy to talk about the community-led person-centered TB responses on the ground by Humana People to People India. And I also will cover your question about stigma, addressing stigma among marginalized community. So Humana People to People India is registered in 1998 and actively working on TB for past 10 years, reached almost 3 million marginalized people, especially in urban cities of India. So according to National TB Elimination Program, approx 80% of TB cases belongs to marginalized community. But the challenge is the health-seeking behavior of this community is very poor. And the health care system also face challenges to reach them effectively. And as you mentioned already that there is a lack of TB knowledge and understanding among these populations. So therefore, high stigma and discrimination they face in day-to-day life. The major challenge is that there is a lacking in treatment support to who are identified with tuberculosis among these community. Because after initiating treatment, comprehensive social support is needed to manage with the treatment. I have mentioned some of the challenges, but all challenges on the ground can be addressed through community-led, person-centered responses.
Yeah. So thank you, Jahangir, for the response. And Jahangir, again, can you also describe a little bit about the Humana model in reaching out to the urban, vulnerable, marginalized population?
Yeah, so thank you. So we provide a comprehensive person-centered TB care through our TB projects in Humana People to People India. We work with vulnerable and marginalized communities like people in slum, migrants, and the homeless living on streets, under flyover, and at the public places. We bridge the gaps in accessing TB services from the public health facilities. We reach community in challenge. Yeah, reaching these communities challenging during normal working hours. We do we do that 9 to 5. If you like to reach these community, then it is very challenging. So we applied some different approaches to reach them. So therefore, we should means be aware about their hotspots and time to get most of people out there. Then we can plan accordingly that when should we reach these populations? We should be reached in early morning or late evening. And then we provide quality cascade of care, including TB information, screening, facilitate testing and treatment, prevention and treatment support. Important part of our TB care is to provide comprehensive treatment support to the people diagnosed with TB, where we do intensive follow-up visits throughout the treatment period. That includes daily visits during initial 15 days and later weekly visits. So this approach, as per our experience, has shown that it has contributed to better treatment outcomes and reduced loss to follow-up cases. Yeah, and then we are able to provide quality cascade of care because we deploy health workers from same community and provide comprehensive training every quarter covering TB knowledge, communication skills, and importance of person-centered care, so that they can provide quality TB services on the ground. Apart from it, we have good collaboration with the National TB Elimination Program. Yes, and then we have consistently refined our approach to improve TB case detection and deliver high quality care services by integrating technology into our TB care and TB care services.
Yeah.
After including technology, we have achieved a higher yield of presumptive cases and confirmed TB cases among vulnerable and marginalized communities. So this approach we have recently, means before 2 years, we have adopted into our TB work, that we use technology to enhance yield of presumptive and case detection also. So this is all about our model which we implement throughout our all the projects where we help to urban marginalized people, to empower them and to support them throughout the cascade of care.
Okay, thank you, Jahangir. And this is very important to know that and to understand also that you have built the capacity of the community volunteer or health workers from the same community, which actually had helped you in reaching out to the vulnerable population. This is very important, Jahangir, and it's also important to address stigma. So, Jahangir, my last question to you, if you can briefly tell me or tell the group here that do you have any possible solution for community-led, person-centered TB responses?
Okay. Yes. So right now, yeah, few suggestions they are coming in mind. So first one is that engaging more NGOs and community health worker in the TB response who can work on the ground with people-centered approach. This is my first possible solution. And second one is bringing TB services and tools closer to people, reducing travel cost and time burdens, so that they can also avail all the technology and TB services closer to them. And third one is providing comprehensive training to means community leaders, TB champions, and community health workers, means covering all the aspects of knowledge like TB knowledge, community skills, communication skills, and the importance of person-centered care. So yeah, right now these three possible solutions they are coming in mind. And yeah, so Yeah, so apart from this, I have one quote that when people know and understand, then they will be able to take action for their own health. So that is means last message from my side.
Thank you, Jahangir. Thank you so much for all these responses. And since Shobha and Bobby, I do not see even the chair or Manoj are there. So I'm just taking the opportunity to ask few more questions to Tariro and Jahangir, and I don't know if Michael is there or not. So Tariro, I'm going back to you again. And Tariro, you being a global leader, with the present situation, the current situation of uncertainty of funding, and the even the USAID funding gone down to larger extent. How do you see that we can sustain the motivation of all these TB champion, TB survivor group, community volunteer, the health worker in the field, and ensure that at least they are doing their work in the field with whatever little bit of support we can provide.
Okay, thank you so much, Suprat, again for the question. The 8 cards came in as a shocker, and it really negatively impacted in programming, yet on people living with the diseases and communities. But if we want to move forward, we have to keep our light on, and we have also to have some learning which comes with it. So while it disrupted a lot, but let's take it also a step further in a more positive way, that it was a learning wave. And what needs to be done is we need to work leveraging on our partners, our all-weather partners and so forth, how they can strengthen domestic financing agenda, and also putting everyone on board, private sector. Give you an example of my country, Zimbabwe. We've got even Southern Africa, we've got a lot of resources. SADC, there's mining, we've got a lot of resources and so forth. So how can we leverage on this and put private sector as part of the agenda to resource mobilize for communities, people living with diseases, TB survivors, people living with HIV and AIDS, all those, our cadres, community health workers, they are always the first to be interacted with anything, be it COVID, be it whatever, it's them. But where are they now without funding? But yet we have got a lot of resources. So the domestic agenda is very key, and we have to also engage with the private sector. Not forgetting also the other lesson we learned from this is our pots of resources. We should diversify at country level and so forth. Like we were so relaxed. Like TB is the least funded across the globe. And everyone was just looking at stop the partnership, and it was doing it. And they're still doing it, encouraging us and so forth. But also they need help. We need to diversify our pots of resources from our nations and so forth, so that our partners, but we have to leverage on their capacity. We have to leverage on their technical assistant. We have to leverage it on their tools. We have got so many tools to help us to come up with all what we are talking about, this domestic financing. We've got so many tools. And also, I think our regional ports, the SADCs, the AU, or the Asia, whatever, all these boards also should be part of the agenda on domestic financing.
Absolutely.
That way, I think that way we can move on. We can keep on the light to end pandemics.
Thank
Over.
you, my sister Tariro. I think these are the real encouraging words, Tariro, which keeps us moving. Having all the difficulties around with uncertain funding and everything, all of you have made actually, or you all have ensured that we sustain the community engagement. We move the community worker in the field, doing their work, supporting the person with TB or HIV. And that's something which is very important, because for me it's like, it's not only diagnosis is important, screening is very important, which the National TB Program Manager said. They are all important part, but from a place where Jahangir was talking about, a place where not people, they sleep and they move out in the morning to go do some work with all the kind of vulnerability around. And if someone is not there, not reaching out to them, then we are missing that person. And Tariro, you are absolutely right. We have to move on. We have to see that how the person-centered care, how the community engagement can be really useful in moving the agenda of ending TB by whatever year, I do not know, 25 or 30. That's something, a kind of a target given, but we also have to see, we have to work together, hand to hand, join together to see that the community engagement, the people-centered approach to TB also be there. So thank you all the panel member. We have Bobby, I think we have Shobha, we have time to take 1 or 2 questions.
No, we can take questions from the audience. I will ask the audience
Exactly. So the session is now open for the questions.
So
and it's good to see that there are still 48, 50 people are still listening to this community engagement part. So are there any questions from the audience, please?
And thank you for conducting this panel so well. So
just a comment.
Yes, Sugata, Dr. Sugata, please go ahead. Yeah.
Especially for our friends of Africa, because probably it would be very difficult for a huge country like India with a huge population, but the smaller countries of Africa where TB burden and HIV burden is high. So my suggestion to my friends of Africa is that why not you start an advocacy to merge these two programs into one program, because your target population are same, the pattern of the disease they are also same, and both the disease are having huge level of stigma. So why not you merge the two programs into one program with under one leadership, under one strategy, under one monitoring, under one service provider, so that you can also save a lot of resources. Because now what happens that there are two separated programs, there are two separated funding, but if the programs are merged, I'm quite confident that you will find a lot of good funding support for your people. So that's my basically a kind of suggestion for you, that please strongly advocate to merge these two HIV TB program into one, because the people who are vulnerable to TB, they're also vulnerable to the HIV and vice versa. There is absolutely no doubt about that. So when your patient, when your vulnerable community are the same, why you have separated the two programs? Merge them in one, and then I think you will get a lot of operational advantages. Thank you so much.
Excellent point, Sugata. We have noted down your point. Are there any other comments or questions? We still have another 5 minutes.
Yes, I think, yeah, thanks a lot, Subrat. I think we have Dr. R.K. Sood amongst us also. who leads, who has been the DTO, district TB officer in Kangra, and also the district health officer now in Kangra, Himachal Pradesh. And what Sugata was saying, I think, of course, this is not Africa, this is India HP, but he has been trying to integrate. Dr. Sood, are you there? If possible, please unmute yourself, and it will be great to hear from you.
Yeah, it would be good to listen from Dr. Sood if he's around.
Yes, he's around.
Dr. Sood?
All right, okay. Maybe Tariro is here. Tariro, will you like to say something? Yeah, sure. Time to break the walls, Tariro. More walls.
Tariro would like to say something. Yeah, go ahead.
Okay. Thank you so much. I think I heard you, and I think I said about it to say it's a integration and integration and integration. Not only HIV and TB. If we look at KVP, TB, KVP over HIV people living with HIV, and I think like in Africa, 50% of our TB is HIV correlated. And not only that, we have group of people who are now aging with HIV and AIDS. We have been on treatment for more than 20 years and so forth. And those people went through phases in terms of treatment. Number one, phase one, there was no medication. They were relying on information, the establishment of IAS, understanding giving each other hope in a support group. Second phase, we embarked on herbals. Third phase, we embarked on treatment camp, but that treatment was toxic, and most people were left out deformed because of the treatment. But we did not tire. Now we are in the fourth phase where we have got tolerant medication, but those people are not living with one condition. They are living with not less than 3 conditions. It's HIV and AIDS, recurring TB, it's hypertension, it's all different comorbidities and so forth. But they are still soldering on. So when you are talking integration, even when you are talking HIV, TB, we are not saying the entire thing. A lot. What about MR agenda? What about isolation when we talk about mental health issues? So there's a lot. But all we are saying is integration. While TB and HIV is the basis of all these other comorbidities, we are saying integration, and stigma must go. I thank you.
No, Tarino, thank you so much. And I could see in the chat box also, Rasmi Kumar C has also written around the same thing, Tarino, about bringing in NCD care and aging related care under same roof, one-stop center. So I mean, they all would like to see that it's not only TB or HIV, also beyond TB and HIV. But that's something, a great suggestion. So Dr. Sood, now I can see you, and please go ahead, Dr. Sood, if you have any comments or inputs on this thing.
Yeah, Dr. Sood, first of all, our heartfelt compliments and regards to all your team. I read a few days back that it was raining heavily in Himachal Pradesh, but there were over 300 people lined up for TB screening, and Dr. Sood's team kept on working till 10 p.m. in the night despite heavy rains and screened all of them with X-rays. So salutes to Dr. Sood. Over to you, sir.
Thank you for having me and giving me an opportunity to add on something. So, like Dr. Urvashi said, and all the learned speakers gave inputs, there's a lot of active efforts going on right now in TB and HIV. But the real thing, I think, is to sustain the passion, to sustain the energy. That is the real challenge right now, that people continue with the same passion and energy, like the Shivir which you're talking about. Even at 10 p.m. We had our ASHA female volunteers who were bubbling with energy, and like they were not ready to leave. Like we had to literally close the camp, that like enough for today. So that is the energy levels we are looking at, and this is enthusiasm we want to sustain, I think. And rightly said, we need to address the stigma more and more through open dialogue, and I think better communication strategies, better what you call targeting of the people, so that people come forward to avail those facilities. So I think it's been a wonderful discussion with all of you, I think, and really enjoyed today's session. And I think we definitely we all move forward from here and learn from each other, and that's wonderful learning today, sir.
Thank you so much, sir. Thank you for really been around for this session, and what Bobby said, and we can understand the situation in Himachal, but we really appreciate it, sir. We have one person, Peter. I could see your name in the list of participant. Peter. Oh,
yeah, hello, he's here, Peter Oviti. Hi, Peter. Can you unmute yourself, Peter?
Where is Peter? He is a real champion in the community engagement, and he's not speaking. Oh no, I think he dropped.
No, he is here. He is here.
He's there.
Now,
hi, Peter. No, I don't think he's there, Bobby.
Peter, can you try one more time to unmute?
I think he dropped out. Maybe. I can see Peter here. Yeah. Okay. Anyway, thank you so much, all the panel members, and it has been really interesting discussions around people-centered community engagement care for TB and HIV, with the experience of the people like Tarido, who is not only in Zimbabwe, but she is a kind of a global person, global face. We heard Jahangir. Jahangir is implementing a community-led initiative in urban slums. We heard also Michael. So, and unfortunately, we missed a few of our participants today, probably because of some other engagement. But this is something very interesting. I think this is one of the area which I have that passion and to do some work around community engagement. We have been doing it. And thank you, Bobby. Thank you, Shobha, for organizing this event, organizing this kind of meeting, and bringing in the community perspective as a dialogue. So thank you so much. Over to you, Shobha.
Thank you very much, Subrat, for conducting the panel session so well. And with this, we come to the close of today's IAS 2025 affiliated independent event, which brought together leaders on the front line at all levels, local, subnational, national, regional, and global, along with affected communities to find person-centered solutions to expanding access to health technologies with equity and rights and human dignity. My sincere thanks to all the speakers and to the audience for their invaluable inputs. We've heard some very good positive examples from across the global south. As Dr. Rewari mentioned, that the year 2025 marks the historic point where the Global Fund has procured Africa-made life-saving ARV therapies from UCL Kenya to be delivered to Mozambique. And another highlight has been the Africa CDC and UNAIDS have formed a new strategic partnership at WHA 78, that was in May 2025, to expand the production of essential health products in Africa and improve sustainable access to medicines, diagnostics across the continent. Let us hope that these positive changes will multiply and not only strengthen, but also acknowledge the role of Global South in helping end AIDS, end TB, and deliver on SDG 3 that focuses on ensuring healthy lives and promoting well-being for all at all ages. Namaste. Have a good day till we meet again.
Thank you, Dr. Shobha and Bobby. Thank you so much. Namaste.